Good afternoon, everyone from your region, I think. It's a great pleasure to have such a wonderful webinar in between the ACNS and the Bosnia and Herzegovina Cerebrovascular and Neuroendoscopy webinar. So I visited Sarajevo once. Of course, Professor Lucas, he invited me. And also I remember that all of you, and you were so kind and very warm welcome. And also I brought the several Japanese colleagues the meetings. It's a good memory for us because Sarajevo is very famous for winter seminar, Olympic game. I think it's a really nice place. And also the Dr. Adi, that he is one of my MC tonight. That he studied with us the 3-4 months. So that's why that we scheduled the webinar today. So today I'm very honored to have a society president, Professor Ibrahim, and he's a great leader of your region. And I think maybe in the future, I think Asia and your place we have a lots of collaboration, not only the scientific, but also some the cultural, every exchange, I think, things. So it's quite difficult to say the president's name, Ibrahim Omerbodovic. Is okay? Not bad? Is okay?
Yes.
Okay, thank you very much. So anyway, we have 5 speakers tonight, and the 2 is great endovascular teachers, and 2 endoscopic, the great teacher from Japan, and last one is really the cerebrovascular teachers. I think you can expect their the very great lectures. I think. And also one more thing I would like to introduce Dr. Liu. He is almost arrangement of this meeting. So I really thank you very much, Dr. Liu, for your great support. So let's start. So maybe I would like to introduce the Professor Ibrahim, the Society President of the Bosnia and Herzegovina. Please start. Your turn, please.
Good evening, everybody from Asia. Good evening, Professor Kato. I'm honored and pleasure to be here with you tonight, like the part of this nice event and also like part of organizational board. Of course, the most important and the biggest effort was to organize this meeting was made by Professor Kato and her team, especially Professor Liu and our colleague Adi, but also other members of the ASEAN Congress of Neurological Surgeons, and especially Japanese colleague of Neurosurgery, Endovascular, and Endoscopic, and the part of the team from Bosnia Herzegovina Society, and also Southeast Europe societies. We are very pleasure to hear your lecture tonight, and this is something like educational course and joint meeting between our societies, and I hope that not only the young colleagues but also we in middle age and older can learn today many things, many new things, and some gold standards for endovascular endoscopic neurosurgery. So you are all welcome to Bosnia again after 5 or 6 years. It's time to see you again, but we will see what will this pandemic bring us in the close future. However, I expect you here and at least I hope I will meet you somewhere in live on some congresses. So let's give a chance to our professor teachers tonight to give us a lecture. Today actually is the 11 a.m. in Europe, in Central Europe time. So we are in the Sunday morning and you are in the Sunday night. So we are all happy to talk and listen tonight lectures. So thank you. That's it. I want to say just for the beginning few words.
Okay, thank you, Ibrahim. Before I hand over to Lucas, just I want to tell my Japanese colleagues, because I got some information about Bosnia and Herzegovina, some information about neurosurgery from Almil. You have 6 centers, and also the board certified doctors and the 10 residents. And of course, Sarajevo is the biggest city and biggest service, and 9 doctors and 2 residents. Is it right? And almost
that's it. Correct. Okay. Something like that. 40 neurosurgeons in 3.5 million people population.
Congratulations. And yearly, the case is almost 1,000, maybe more than 1,000, I think. So yeah. I think, is this right? Okay. So I think,
yes, that's it.
Yeah, I saw the several pictures of which Almir that he sent us. What a nice operation theater. But you said, he said you have a variety of the surgery, but except for the functional neurosurgery. Is it correct?
That's all. The probably biggest problem with the functional neurosurgery, we still didn't organize and solve this problem well. So I hope in the close future we will do that in a better way.
So in the near future, maybe you will have such a functional neurosurgical service, I think.
Yeah, right.
So then I would like to introduce Dr. Lucas from Serbia. He is not only the leader, but also very humanistic, the person. He covered all Southeast Asia, and also he made so many role of the leader in the world, I think. So Lucas, are you ready to talk?
Yeah, yes, I'm ready, Professor Goto. Thank you very much for your kind words, and I would like to greet you all from this southeast part of Europe, and on behalf of Southeast European Neurosurgical Society, to thank you all for your outstanding support, your personally, Professor Goto, and all colleagues from Japan who anonymously support our development in neurosurgery in this region, in each individual country, with correlation and coordination and cooperation with each individual society, as well as our regional society, Southeast Europe Neurosurgical Society. So this is one more outstanding educational activity which we organized today together with Bosnian Neurosurgical Society, Association of Neurosurgeons of Bosnia and Herzegovina, and Ibrahim Overhodzic with their colleagues from Bosnia. I can see distinguished experts from cerebrovascular and neuroendoscopy field of neurosurgery from Japan here. And just what to say more that we appreciate very much your continuous support and friendship, and we really would like to continue our joint ventures in future and to see you all here in Southeast Europe as soon as possible. Might be first opportunity to see each other here in the region, while I hope that this pandemic crisis situation will finish until the middle of this year will be in October this year when we have a European Congress of Neurosurgery. You are more than welcome to join us, and we can of course send all this invitation to you, but you have an open invitation to join us in every manner. So once again, it's my pleasure to be today with you and to learn from Japanese colleagues and experts. And I am on disposal for any kind of future collaboration, as you offer us very generously, Professor Kato, to accept some of our young neurosurgeons to come in Japan to be our fellows and the fellows of distinguished Japanese colleagues, experts. So this is something which is of outstanding importance to neurosurgery, for neurosurgery in this region. This is a rare opportunity that regional neurosurgical societies are in a situation to have such a strong support and possibility to learn from experts such as experts from Japan. So once again, thank you very much, especially to you, Professor Kato. Thank you.
Thank you, Professor.
Yeah, I will now leave the floor to you and to Ibrahim and to Adi to moderate the sessions, and I'm on disposal, of course, if you need me for anything more to join for any kind of moderation, of course, discussion.
Okay, thank you so much. It's a wonderful word, Lucas. So maybe you can invite all of us, please, for the European Congress, maybe. Thank you so much.
I will.
Okay, so we move to the program, and I would like to introduce Dr. Adi. Hi, Adi. So maybe you can say a few words before we start, please.
Just let me welcome all of you again. I'm so glad that we organized this first, we can say, meeting between ACNS and Bosnia Neurosurgical Society. And thank you for all of your support, Professor Kato. And also, since the Japanese people are great friends of the regional nations and of Bosnian nation, I would love to express compassion for last Kyushu earthquake in Japan and to all victims of Japanese people who were in this earthquake. Anyway, respecting the time, I think we should move forward. So let me first introduce our first speaker, Professor Akio Hyodo, who is the chief of Neuroendovascular Therapy Center, Kamagaya General Hospital, Kamagaya City, with the lecture Endovascular Treatment of Cerebral Aneurysms. Professor Hyodo, I would kindly ask you to start your lecture.
Just I want to tell one word, because Dr. Hyodo used to be the society president of the Endovascular, Japanese Endovascular Society. He did 4 years. So he is a master of the endovascular, I think. Please.
Okay, this is my turn. Do you hear me?
Yes.
Okay. Good afternoon and good evening, everybody. And also thank you very much, Chairman and Professor Yoko Kato, for great introduction to me. Okay, so today I have to share my slides. Okay, from now. I have to talk about the endovascular treatment of cerebral aneurysm. And oops. Actually, already introduced by the chairman for me. I'm quite old right now because this is the 46th year after graduate from Chiba University School of Medicine. Actually, I worked for a long time with a subspecialty for the treatment of cerebrovascular disease and both neurosurgical and endovascular surgery, so-called hybrid neurosurgeon for a long time. So far, I performed a neurosurgical operation 2000, and the neuroendovascular treatment, it's almost 6,000. So it means, this is my personal records, annual records of the number of procedures. the pink dot indicate the endovascular treatment, and the blue dot indicate direct surgery. So, this year, 2017, I retired the chairman professor of neurosurgery. So after that, I quit the direct surgery, but still I continue to do work at the endovascular surgery. So today, I like to talk about only endovascular surgery. So as for endovascular treatment, everybody know that is a special technique, percutaneous transluminal catheterization, and to reach the vascular region through blood vessel, and embolize or recanalize the vascular region, or selective drug infusion or endovascular diagnosis. And usually from transfemoral approach we prefer, but sometimes, of course, transradial or transbrachial we can choose. But, all inside the blood vessel, we don't have to cut anywhere. Just put a small pinhole through small pinhole to the catheter. So this is a cervical portion. After aortic aorta, the many several four, just four, carotid and vertebral both sides. And after internal carotid, we can reach intracranial cerebral artery. It's very easily. And let me start about the cerebral aneurysm treatment. The cerebral aneurysm is the most important cause of suborgan hemorrhage. And once ruptured, bleeding rate is very high. Almost the mortality rate is very high. The risk of rupture, but the risk of rupture of unruptured aneurysm is not very high, something like 0.5 to 1% per year. That we have to discuss the indication how to treat the unruptured aneurysm. But ruptured aneurysm is mandatory to be treated. So, and in order to prevent rupture, we have two technology. The one is neurosurgical clipping, and the one is endovascular coiling. It's almost everybody knows, just like this. The left is that clipping, the right in the endovascular surgery. The direct surgery, of course, we need open the cranium, but endovascular surgery, we don't have to do that. Already I said. So from now, and I have to talk about endovascular treatment of cerebral aneurysm. So this is again my personal record. Just focus to the cerebral aneurysm. Pink dot is a treatment of cerebral aneurysm endovascularly, and blue dot is a direct surgery. It means clipping. So far, I have treated endovascular direct surgery just 800. Instead of that, the endovascular surgery almost near the 3,000. And I have to say that even recently, I have to do every year, maybe average 150 cases. So still doing something. So, today I can speak about the endovascular treatment of cerebral aneurysm, even, with the new devices. Okay, something like this. Recently, we can use many new devices, something like flow diverter and even and bridge, intrasaccular flow disruption devices. So I will talk this kind of procedure later. So aneurysm is existed in the the cerebral blood vessel, but almost located in this circle virus. So this portion is from the outside, it's very deep, and it's very difficult to reach. But from endovascularly, once we can get, the vertebral artery or internal carotid artery, just after that, they're located in the sacral wheels. So, the ECOM and, the basilar top and the MCA, this is almost the 90% is located near the sacral wheels. It's very near from the outside, the inside the blood vessels. So, but, in order to perform the endovascular treatment with a good result, we need some equipment and some devices. So so-called Trinity of the endovascular treatment. One is digital subtraction angiography, DSA, and also microcatheters, and finally embolic materials. DSA, everybody knows, and you can see in the angio suit, recently we use this kind of flat panel detector, and the biplane, especially biplane, this is if we can only use the single plane, it's sometimes it's a little bit risky, but using the biplane machine, we can do with a very, very good quality. And also recently, in my angio suite, this is the newest machine made by Siemens, the artist iconodispin. There are a lot of great abilities. And this film shows just angiogram with a bone. So this is right internal carotid angiogram. This is aneurysm, isophthalmic aneurysm. And this is a digital subtraction image made by a DSA machine. This is aneurysm. And also this machine makes a 3D image very easily. So we can see like that. And also, we can see from any direction. So the aneurysm treatment, we can see where the neck of aneurysm is very, very important. So we can detect using this machine very easily. Here, right? And also, we can use this kind of so-called road mapping images to navigate the microcatheter and to insert the coil. Actually, this is aneurysm here. And also, this is a balloon. I will explain later. Anyway, and put the microcatheter inside the aneurysm, and also push the platinum coils inside the aneurysm. We can see very easily with this map, okay? And also microcatheter. We can use commercial-based microcatheter recently, very, very, easily. So this is 0.7 millimeter. This is 1 millimeter. This is 1.2 millimeter. Anyway, it's a very, very small microcatheter. Only microcatheter cannot navigate directly inside the blood vessel in the brain. So, we have to this big guiding catheter up to cervical portion, and then inside the guiding catheter, we put it the microcatheter in, and sometimes 2 microcatheter or 3 microcatheters inside 1 guiding catheter. And this is it's a setup of the microcatheter navigate with the microguide wire and also guiding catheter. So in between, we use the hyperonized saline and to prevent the clotting. And the microcatheter, even the very, very tortuous blood vessel inside the brain, but still we can push the platinum coil. I will talk later. push easily like that. And this is the cerebral angiogram from the neck. So this is cervical option. This is a microcatheter. Microcatheter is recently, it's a very, very easy to navigate, even the, the very, very distally. Okay. And finally, embryonic materials. So at the beginning, maybe 30 to 40 years ago, we only used this kind of balloon. The detachable or non-detachable balloon. We can use only this type of embryonic material, and also some particles. But from 1990, he is Professor Guido Guglielmi. He invented the GDC Guglielmi detachable coils with Fernand Benura in UCLA in the United States. And he presented a paper, Journal of Neurosurgery. It's a very, very famous paper. After that, we can use, this kind of platinum coils. That's just, push inside the microcatheter. And using these coils to like this, microcatheter put inside the aneurysm, and this coil push as tight as possible, like this. That's it. Recently, we can use that. So many platinum coils, and there's something like 3D shape, and also the 2D shape, the different, this is the fit for the different shape of aneurysm. And I already said like this. This is a real, image. This ICPC aneurysm, the very, very weird figure. But still, the platinum coil, spread whole of the aneurysm inside, like this. The first we put the little bit rigid and the form platinum coils, make a framing, and then the filling. The last, finally, the finish. So that's it. We don't have to cut the brain. We don't have to open the skull. So this is, the aneurysm, and finally like this. And this is movie. So microcatheter tip is here. And, this is basilar top small aneurysm. So microguide wire. So we can, navigate the microcatheter like this. So finally, the tip of microcatheter inside the aneurysm. Then we push the coil like this, as tight as possible. That's it. Okay. So this is the well-known and the very famous the study, International Suborganization ISAT, reported in the 2002. This study was organized in the European country, mainly in England, French, German, or something. And this result showed the endovascular treatment of ruptured aneurysm is a little bit or much better than direct surgery clipping. So after this result, almost all European countries, they changed their mind. The first option to treat the cerebral aneurysm, ruptured cerebral aneurysm, shifted to the endovascularly. But in Japan, still, we are so many neurosurgeons like to do clipping. So up to recently, initially, maybe 20%, just 30% of the cases treated by endovascularly. But finally, recent couple of years, even in Japan, a little bit more endovascularly treated for the cerebral aneurysm. So the endovascular treatment of cerebral aneurysm performed usually a simple technique using only one microcatheter. But if the aneurysm neck is big, a little bit bigger, so it is very difficult to make a tight packing of the platinum coil just using the simple technique. So we need some adjunctive technique. Sometimes using double catheter, 2 catheters, 3 catheters, and sometimes using balloon catheter to assist not to protrude the parent coils to the parent artery. And sometimes a stent assist technique, like this. This is simple technique, just one microcatheter and coil. And this is balloon assist technique. When we put a coil, inflate balloon to protect the coil protrude the parent artery. And this is double catheter. It may be 2 microcoils, simultaneously push, so that we can make the very, very good form, the framing coil. So this is stent assist coil technique. Stent, I mean that support the coils, not to protrude to the parent artery forever. So let me show the balloon assist coil embolization a little bit more. So it so-called balloon assist technique, and also reconstruction or remodeling technique, and sometimes called neck plastic technique. This is introduced by Jack Morley. He's still doing some lot of endovascular surgery. The reconstructive technique in the treatment of wide neck intracranial aneurysm, long-term angiographic and clinical result. There's 1997. After that, a lot of people are using this kind of balloon assist to protect the neck. And the role of balloon is not only protect to protrude the coil into parent artery, but also support the microcatheter or stop bleeding during intraoperative rupture, just in case, and much more. And recently, this kind of the dual lumen balloon catheter using the neck plasty remodeling technique, we prefer to use this kind of devices. So this is also again my personal records. This blue dot indicates the total number of endovascular treatment of cerebral aneurysm, and the pink dot is within that using the balloon catheter. So it means even still recent couple of years, we still use lots of cases the balloon assist technique. There's still more than 50% of case we use the balloon assist technique. And the yellow dot indicates the stent assist. Of course, stent assist we use certain amount of cases. So this is stent. So at the beginning, stent is just a balloon mounted stent, but recent more than 10 years, the very nice stent just pass through the microcatheter to open, and we can use it. So the user this type, we can very easily to perform the coil embolization like that. So this is another stent. So like this, the stent, even this type of this kind of ultra wide neck aneurysm, still we can do the coil embolization to make a tight packing like this. So this is the stent. So let me show the representative cases. This is a balloon assist technique, the ICPC aneurysm. So this is the the tip of microcatheter. This is balloon. The first, just the put of coil, and then the part of coil protrude to the parent artery like this. Then inflate balloon, and put the more coil and make a tight packing like this. And this is the ACOM, and no contralateral A1, so we protect both A2, and in that case we put even the two balloon like this, double balloon technique. So once we can make the two balloon assist technique, and it's very easy to make a tight packing after that like this. So this is final. And even the center assist, at that time, we preferred even for the center assist technique. The first I try to do balloon assist technique like that, but if the balloon deflate, the part of coil must be protrude in the parent artery. So after that, we put the stent like this. The stent is already open and make a tight packing. And this large vaginal top panel, we put the two balloons and the double catheter like this, and then make a tight packing coil. And recently, we can use some kind of new device to make a tight packing. The pulse rider is like this. It's a very, very, not many metal inside the parent artery. So just like stent, if I put a stent like this or Y stent, this is mandatory to do the dual antiplatelet for a long time. But this type of pulse rider, so maybe it's just a very, very, very few period we give the dual antiplatelet. After that, we decrease. And I just using the two cases, this type of MC aneurysm, we insert the pulse rider like this here, and then put the microcatheter transfer inside the aneurysm, and to make a tight packing like this easily. So from now, I'd like to introduce a new era, endovascular treatment for aneurysm. So far, only using a coil to make a tight packing, but sometimes the only coil is become recanalized. But even though more than 80% of cases is okay, but especially large or big aneurysm, and also the wide neck aneurysm tend to be the recanalized. So we need new devices. Endovascular treatment of cerebral aneurysm using new device, something like flow diverter or intrasaccular flow disruption. There are so many, the commercially available in the world. First Medtronic pipeline flex, and also the Phenox P64 or Bardo Silk, and the thermal microvention made of thread, and Striker made of supper. So, but in Japan, only we can use an pipeline servers thread, only three types of flow diverter. As for the intrasaccular flow disruption, the web is very famous, but also the contour, there such a couple of other devices already available. But in Japan, just recent year, we can use the web devices. Just started to use. So far, I performed the pipeline and 200 and the FRED 28 because pipeline and started 6 years ago, but FRED the 1.5 year, and the surplus is just 1 year. So the this discrepancy. But again, this is my total number, and so far to 2070 700, and this orange line indicate the flow diverter. So at the beginning only pipeline, but recently including that the FRED or surplus of course. That so far totally I participate flow diverter treatment about 229, but the number is like this. And let me show some pipeline. The pipeline, maybe everybody knows that this is the 48, the steel wires. It's a kind of a mesh stent. It's a very, very thin hole, and like this stretch or shrink. And this is deploy after deployment. So, and this is a movie of animation. This is aneurysm. Just using a little bit big microcatheter and pass through this microcatheter pipeline to push the open and deploy, and that's it. After deployment, at the beginning, still flow inside, but after a couple of months, the flow stop, and the new endothelialization covers the whole stent surface, and then the aneurysm shrink. That's here. The deploy the pipeline flow diverter, with a special technique a little bit. But after 10 or 20 cases of experience, it is not so difficult. This is a real image. This I see cavernous aneurysm. The first, this is a 4 times speed, so the linear too quick. But anyway, the first we navigate the microcatheter and push the pipeline like this. And this is the tip of microcatheter. Push the pipeline. Then pipeline, the tip is a little bit open. The once open, we push like this. Then the tip of microcatheter center, and the push again, and this is open. Finally, this is open, and deploy. But after that, just confirm the full expansion. We prefer to make angioplasty using a microballoon catheter like this. This is a microballoon here, inflate, and the full expansion of the parent artery to deploy the pipeline itself like this. So this is it. And other flow diverter is a FRED. This is almost same, but dual layer. There is a different and much easier to open it. And this is surface, but in Japan, the only we can use the surface streamline. It's a little bit different. Already pre-mounted stent. So the how to deploy is a little bit different, but this is a little bit different flow diverter. It means much more steel wires. It's I already said the pipeline is 48. This surface is almost double. The 5 millimeter streamline is 96. So maybe much more flow diverting effect. This is a result of my personal experience. This is Tokyo University Southern Medical Center is my one of the home hospital. At that time, so far 132 flow diverters already used. The pipeline 104, Fred 24, surplus 4, or something like that. And then all cases, deployed successfully. But the complication is 3% morbidity and 2% mortality. Unfortunately, very, very few, but still mortality we expect. And this is imaging follow-up. The 1 year follow-up, the OKMD DC is almost cured. It's a 1 year angiogram indicate the 60 plus 22 means 82% almost cured. How about 2 years? The 98. 3 years, almost 100%. So this is well-known report, the PUF study. After 5 years, 90%, 95% of cases are cured, angiographically cured. So it's a very, very promising device, I think. So this is the real case. The 22 millimeter IC cavernous, 1 year is cured. And also the IC paraconoid, cured. IC ophthalmic, this is Fred. They're different, right? Fred. Also, this is an ophthalmic artery. The aneurysm is cured. This is a small but wide neck. So usually we need a stent. But the only Fred cured. So this is another. It's a kind of tandem region, the multiple aneurysm using Fred, also cured like this. So it is very, very promising devices, I think. And sometimes the blood blister-like aneurysm, we can make it. But the problem is that even the very few chance, but still some complication. This is a relatively bigger aneurysm. After the 9 days after procedure, this is IC cavernous, delayed rupture, like this CCF. After that, of course, this is cured by transvenous approach. But this type of basilar, big basilar aneurysm, is just kind of megadoric basilar, using a Fred like this. This is the day after, 2 days after procedure, ruptured. Yeah, but sometimes very, very few. So still, I think this is the promising device. So this is web. Actually, almost time to stop. Okay, this is almost the last part. So this is the web. This is animation, contributed by thermal microvention. This is a web. Once this web device, inside the aneurysm deployed successfully. Like this. Of course, this is a catheter-based deployment. So detach. At the initial couple of days, there's still this is the flow, but maybe 3 weeks or 1 month, this surface of the mesh, the some endothelialization make and disrupt the blood vessel. So this is my case, the MC aneurysm, like this aneurysm. The measure, the size. And this is, we deploy the web device like this. Okay, so almost the time passed, more than 30 minutes. I like to finish my talk. So today, I introduced endovascular treatment of cerebral aneurysm, from the beginning to the new era. So just 30 minutes is not enough time, but I did my best. Thank you very much for your attention.
Thank you, Dr. Hyodo. So maybe we can ask Dr. Ibrahim. Do you have any question or your young colleagues?
Thank you, Professor Hindo. That was great lecture and very nice from the beginning and basics to the really experts' opinions and suggestion how to treat complex aneurysms and how to use different type of stents and stents and coils and so. So I would like to thank you, and no question for him from me.
Okay,
But there
so
are
maybe
others who are much more involved.
Dr. Amil, please.
Okay, thank you, Professor Hyodo, for your excellent and very helpful lecture and presentation. I'd also want to thank Professor Kato for your great support. Adi and I intentionally asked Professor Kato for organize this type of webinar to help us in our future development. I have 2 questions for Professor Hyodo.
Yes.
Regarding your great experience, and for us it's very important because you are a hybrid surgeon. So in Sarajevo, we developed this kind of endovascular procedure a couple of years ago, but still we treated about 70% to 80% of aneurysms surgically.
Mm-hmm.
So first question is, what is your strategy regarding the treatment of this aneurysm? What is your first options? Is it your first option endovascular treatment, if it's possible? And the second question is regarding the cerebrovascular vasospasm, because some surgical protagonists said the surgery is better options for reducing the cerebrovascular vasospasm, because with the surgery we are able to wash out the subarachnoid space to reduce spasm. But some studies suggest opposite, that the endovascular treatment is better options in reducing the cerebrovascular vasospasm. So 2 questions: your strategy for the treatment, what do you advise to us to move forward, to shift our strategy, and second for the vasospasm. Thank you very much.
Okay, thank you very much for your question. Very nice question. Actually, the first question, the how to choose, the critical coil, right?
Yes.
I think it's even for myself changing time to time. 20 years ago, we can't use not very nice devices for the endovascular. As for today's my talk, at the beginning, just a simple technique, right? So for wide neck aneurysm, it's not good for the endovascular. But time to time, we can use the new devices, for the even wide neck aneurysm, and recently flow divert or something. So the reason why the percentage of the endovascular purified case increasing even in Japan. I already talked at the beginning. Means the just after ISAT study, the 2002 in the European country, it changed dramatically. But in Japan, at that time, still just 20% of cases treated by endovascularly. 80% are creeping. But time to time, maybe yearly couple of percent increasing. So finally, this 2 years, the even. And, recently, maybe a little bit more endovascularly. So that reason why the device and, some technique improving. So, that's the reason why. It's okay. And so it means that even your country, the number of doctor, interested in the endovascular increase, and also the technique increase, improve, and also the device improve. So gradually, the percentage of endovascular increase must be.
So Dr. Hyodo, what about the vasospasm?
Vasospasm, okay.
Yes.
Yeah, vasospasm. The vasospasm, right now, we saw the vasospasm case. The first, to treat the, maybe sometimes something like angioplasty, just for bigger vessel, the IC-M1, something like that. But M2 or distal part, we infuse some vasodilator drug. So and simultaneously we can treat the aneurysm, via endovascularly. So recently, especially for the vasospastic patient, we can the first choice is endovascular treatment. But maybe 10 to 20 years ago, the many research published. At that time, you already told sometimes the endovascular approach is much better because we cannot touch in the subarachnoid space directly. So yeah, so I can't say anything more, but maybe for the vasospastic patient, I think endovascular approach is better.
So Dr. Hyodo, what's the percentage of
Percentage.
the vasospasm after the endovascular treatment? Cerebral hemorrhage.
Percentage means the after treatment.
Yes.
Actually, it depends, but still, the severe vasospasm, severe subarachnoid hemorrhage case, sometimes occur. But even though, the almost all cases, but we can approach endovascular again. The once I detect the vasospasm, maybe day 7, day 8, at that time, using angio and simultaneously to infuse some drug or make an angioplasty. Yeah.
So Amil, is it okay?
Yeah. So the conclusion is the surgical treatment is not the superior option, even in a treating to reducing the cerebrovascular vasospasm. Is that?
I think so.
Okay. Thank you.
Professor, may I ask you something, Professor Hyodo?
Yes, please.
How often you use the endovascular treatment for the treatment vasospasm actually? How often you are going inside the vessels to treat, for example, with nimodipine or something after you from vasospasm, after the microsurgery or even endovascular?
Yeah, even after microsurgery, we can make an, if we can diagnose the vasospasm, we can treat by endovascularly sometimes.
How often?
How often?
How many cases, or monthly, or?
Yeah, actually, the ones we can make a detect of, the diagnose the vasospasm using the angiogram. So we can do it right now. Yeah. So
DSA. So you perform DSA and then you decide to do all that.
Yeah.
So you mean maybe symptomatic vasospasm?
Of course.
Yes. Okay.
Thank you.
Everything clear?
Thank you very much.
Thank you so much. So Eddie, maybe we can move to the second one.
Yes, please. Are there any other questions from the audience? regarding previous lecture? Okay, then we can move forward. I would like to introduce Professor Yasunobu Nakai, who is the Executive Director of Intravascular Treatment Center in Yokohama Brain and Spine Center. The title of next lecture is Endovascular Treatment of Carotid Artery Stenosis. Please, Professor Nakai, proceed with your lecture.
Thank you for the invitation of this lecture. Thank you, Professor Kato and Professor Ibrahim. I will talk about the topic endovascular treatment for carotid artery stenosis, especially the carotid artery stenting. So I checked Bosnia Herzegovina is here and Japan is here. So it's very far from Japan, almost 9,000 kilometers from Japan. So I worked at Yokohama City. Yokohama City is nearby the Tokyo. Here is Tokyo and Yokohama is here. And our hospital is here. So you can see the Y-shaped. So image from the Y, Yokohama Y. Our hospital, Yokohama Brain Spine Center, mainly treated the cerebrovascular disease and spinal disease, and including the rehabilitation unit. This is our team. So anyway, treatment of carotid artery stenosis is mainly focused on the second prevention of recurrent ischemic stroke. Most important treatment modalities, medical treatment, including anti-robotic therapy and risk factor control. And surgical or endovascular recalcitralization is carotid endarterectomy and carotid artery stenting. Carotid artery stenosis is diagnosis by using carotid echogram, MR, or CT angiography and cerebral angiography. Such an angiographic quantifying method is widely used in NASET or ECAS method. NASET method is the distal degree of stenosis, and ECAS method is the proximal degree of stenosis. Such an extracranial carotid artery stenosis is more than 5 persons over 65 years have an extracranial carotid artery stenosis measuring 50% or more. According to most studies, the risk of ipsilateral stroke rise with a degree of stenosis less than 1% per year with less than 50% stenosis, but 1 to 5% per year with greater than 50% stenosis. Carotid endarterectomy is standard treatment for carotid artery stenosis. Surgical exposure to carotid artery and removes the atheromatous plaque. Some country, endarterectomy is performed by the vascular surgeon. So in Japan, endarterectomy is performed by neurosurgeon. In symptomatic carotid artery stenosis, CA is recommended for patients with 7 to 99% stenosis after TIA or non-disabling stroke. CA also been considered for patients with 50 to 69% symptomatic stenosis. Men with hemispheric symptom benefit most. This is a very famous study, Sapphire study, patient with severe IC stenosis and high surgical risk. There is no significant difference in long-term outcome between protected case and CEA. High risk features for CA as follows: congestive heart failure, low ejection fraction, unstable angina, recent MI. Mainly, these conditions cardiovascular complications, contralateral carotid occlusion, followed by CA with recurrent stenosis and radiation neck, and high position stenosis, such as mainly anatomical complications. So conclusion of Sapphire, carotid artery stenting should be considered as an alternative to CA for symptomatic patients with high surgical risk. However, this procedure justified periprocedural stroke or death that is lower than 6%. Anyway, asymptomatic carotid artery stenosis, CA should be considered for patients with 6% to 99%. Asymptomatic carotid stenosis, however, CA is of benefit to patients with asymptomatic case performed with a complication rate lower than 3%. If CA would present special difficulties, carotid artery stenting may be considered alternative treatment. This is a CREST study. Over 10 years follow-up, there are no significant difference between CAS and CA with respect to the risk of peri-procedural stroke, MI, or death and subsequent ipsilateral stroke. Okay. This is the Act 1 study. Asymptomatic carotid stenosis who are not at high surgical risks. CAS has not inferior to CA at 1 year. 5 years follow-up, there were no significant difference between all stroke and survival. This is a summary of the studied CA versus CAS. The procedural risk of CA or CAS, odds ratio is 1.54 favoring CA. Standard treatment of carotid artery stenosis considers CA. So if we perform the carotid artery stenting, treatment indication and how to manage the complication are very important. High risk feature for carotid artery stenting, severe AS, renal failure, allergy of contrast medium, or calcified or unstable plaque, IC elongation, and hypoperfusion of the ipsilateral hemisphere. In such conditions, we prefer to choose CA. So systematic evaluation is very important, especially cardiac disease, such as CAS high-risk group, and chronic kidney disease and peripheral artery disease. Emphasize the importance of access route evaluation. Carotid artery stenosis patients have a severe arteriosclerosis. In such a case, frequently observed elongation of aorta and aortic aneurysm, shaggy aorta, ASO, bovine arch, and type 3 arch. In such a case, transbrachial or radial artery approach is recommended. This is the aortic arch classification. Type 3 is technically difficult and complicated. This is the 83 years old male, bilateral arch stenosis. So you can see the type 3 aortic arch with shaggy aorta. So you can see the so many calcification and thick atheromatous plaque in this aorta. So we selected transbrachial artery approach for carotid artery stenting. So neuroendovascular physician must have knowledge of common variants of aortic arch. So most important one is left CCA arise from brachiocephalic trunk is so-called bovine arch. So in this case, so catheterization of the left CCA is very difficult. It's estimated 7% of cases. So such a case, we prefer to use the trans radial or brachial approach. So this is a 73 years old female with left CCA stenosis. This case is anatomically modified previous neck surgery and radiation therapy. So for laryngeal cancer. So we choose the transbrachial approach and access. This is a guiding catheter chip here. Plaque imaging is very important for selecting CA or CAS. So because CA can remove any kind of plaque, but carotid artery stent cannot remove it. Carotid artery stent have a possible risk of plaque protrusion or rupture. So hypoechoic on ultrasonography presumed associated with higher stroke risk. And also, MRI studies have shown that the finding of lipid-rich centrally necrotic plaque are seen or ruptured fibrotic cap or plaque hemorrhage is associated with stroke risk. This is so MRI T1 weighted black blood image is very useful. Such a high intensity plaque is suggested unstable plaque. And this is also same case. Carotid echogram reveals so very low echoic shadow is suggested unstable plaque. Very procedural antiplatelet therapy is necessary to perform the carotid artery stenting. Most cases use aspirin and clopidogrel. So carotid artery stenting medication. So dual antiplatelet therapy is necessary. Setting of the carotid artery stenting. So usually performed under local anesthesia. Arterial puncture site is mainly right femoral artery and brachial or radial artery. So after the CIS introduced, so systemic heparinization to keep the ACT 250 to 300 seconds. So guiding catheter, so 8 French guiding catheter with 6 French inner catheter, so coaxial system catheterized to the target vessel. We mainly using the 8 French balloon guiding catheter for proximal protection. Transbrachial or radial artery approach case using 6 French guiding CIS. So distal protection is delivered through the catheter and placed just beyond the narrowed section of the artery. So filter protection is selected distal ICA caliber up to the 1 to 1.5 millimeter oversize. Balloon protection is using guard wire is a very useful device, but discontinued by the manufacturer. So now available in Japan, distal protection device is filter protection. Is it wire or spider? If the artery may need to be enlarged to make a space for stent, predilatation is performed using about 3 or 3.5 millimeter small balloon. Carefully, vital check is mandatory during balloon inflation. If bradycardia or hypotension occurred, intravenous aspirin or ephedrine to manage it. Stent is placed to be enlarged in the artery and expanded the artery. Stent size selection is proximal CCA, so over 1 or 2 millimeter size. After the stent is implanted, a balloon may be inflated inside the stent to better position the stent against the arterial wall. Balloon size is the distal normal ICA caliber. So also checks the vital sign and manage using the atropine and ephedrine. Possible complication of CAS is as follows. Cerebral infarction due to distal embolism. Risk of distal embolism is leaky plaque or using filter protection. Instant thrombosis due to plaque protrusion. Hyperperfusion syndrome and cardiac complications is another serious complication. So this is a case, 78 years old male bilateral ICA stenosis. So right ICA stenosis is symptomatic. And MRI T1 black blood revealed unstable plaque. So very unstable plaque. So right CAS was performed with distal filter protection. but filter occlusion was occurred after stenting. During the procedure, patients complained restless and left hemiparesis, aspiration in the stent lumen, and then filter retrieve. So you can see the filter was occluded, so unstable plaques. So fortunately, the patient's symptoms improved just after the procedure. So well revascularized right IC stenosis. That's so previous case is the lucky case. This is another miserable case. This is 80 years old male bilateral ICA stenosis. Right ICA is asymptomatic and left ICA is symptomatic. So MRI and echocardiogram revealed both plaque is unstable. So left cath performed with filter protection. This procedure is finished and event. So right side is asymptomatic. So almost same procedure we performed it. So during the procedure, so filter occlusion was occurred. Patient suffered restless and left hemiparesis. So aspiration in the stent lumen and then filter retrieved. Post-stenting, so major vessel was patent, but the patient was still consciousness disturbance and hemiparesis. Neurological symptoms was not improved. One day after the carotid stenting, so you can see the right MCA area revealed extensive diffusion weighted high intensity. So on this case, filter protection cannot capture the unstable plaque, so like the leakage. Hyperperfusion is one of the serious complications of CA or CAS. If the patient exhibits ipsilateral headache, confusion, local seizure, or focal neurological deficit without radiologic change, hyperperfusion syndrome suspected. The presumed mechanism is a rapid re-establishment of CBF after long-standing hyperperfusion and subsequent inhibition of autoregulation. This is a 73-year-old male, right ICA was occluded. But this case has that, so you can see the contralateral left ICA severe stenosis. So this case categorized as a CA high risk group. So preoperative cerebral perfusion study revealed marked hypoperfusion of the right cerebral hemisphere. So we performed left carotid artery stenting using filter protection to keep the left ICA blood flow. Just after the carotid artery stenting, so you can see the cross flow of the right MCA via anterior communicating artery. However, the patient complained headache and confusion. Brain CT revealed subarachnoid hemorrhage due to the hypoperfusion on the contralateral side. So this is an exceptional case. But how to prevent such a hyperperfusion syndrome? So Ogasawara et al. Reported hyperperfusion syndrome after CA case, strict blood pressure control to prevent ICH recommended. However, hyperperfusion syndrome after carotid artery stenting case, no relationship between blood pressure control and ICH. So in such a situation, Yoshimura's proposed staged CAS to prevent hyperperfusion syndrome. So this is a protocol about the staged CAS. CAS case evaluated cerebral perfusion study using the SPECT under 80% CBF and under 10% CVR case. So staged angioplasty performed its first stage. and to get the minimum ICA diameter over 2 millimeter. And 2 weeks later, carotid artery stenting performed to get the full gain of the ICA. This is our case, a 74 years old male. So you can see the left basal ganglia and so border zone infarction. So symptomatic case. So you can see the near occlusion of the left ICA and so insufficient anterior communicating artery cross flow. Carotid angiogram revealed so near occlusion of the ICA and distal ICA is collapsed. Perfusion study revealed marked hypoperfusion of the left cerebral hemisphere. We selected the staged angioplasty. This is the first stage. A balloon protected PTA was performed under general anesthesia. So we can get the minimum gains ICA flow. Just after the CVF study, so relatively so perfusion is improved, but fortunately no symptom. So in the MRA study reveals the ICA flow is so improved. This case is 1 month after the first PTA, and then place the stent completely so revasculate and follow up CVF studies. There is no hyperperfusion syndrome. So how to avoid the complication of carotid artery stenting? So most important, systemic evaluation and plaque image and perfusion study. It is important to make a comprehensive judgment. If the case is categorized as CAS high-risk group, so in such a situation, CA recommended, or if possible, or valve-protected CAS or staged CAS. In conclusion, CAS is an acceptable alternative to CA, particularly for patients who are high surgical risk. Careful systemic evaluation, plaque imaging, cerebral perfusion studies is mandatory to perform safe CAS or CA. This is a nice seaside view of Yokohama. After pandemic of COVID-19, so please visit to Japan or Yokohama City. Thank you for your attention.
Thank you very much, Professor Nakai. So, Professor Ibrahim or some colleagues, any question? So, Professor Nakai, usually how long do you use the antiplatelet, the drug, after procedure? How do you decide?
So in our department, so necessary is so 1 or 2 3 months, and so so many of cases has a cardiovascular disease. So in 3 months follow-up using the carotid echogram, so no stenosis or symptom is so stable patient, so single antiplatelet therapy, so decrease and maintain.
Thank you.
Okay.
Dr. Amil? Yes, please.
Hey, Professor Nakai, thank you very much for your excellent presentation. Just one question. What is your strategy in asymptomatic patients, but with radiologically confirmed severe stenosis, for example, 85 to 90%? Would you treat this kind of patient, or depends on some risk, but in asymptomatic patients?
So if the patient has not so much problem of the cardiovascular or other systemic disease, so we choose CA or stenting. So that's carotid artery stenting. So many randomized study reveals that more young age patients is effective. So more older patients is CA is better. So in such a situation, we prefer to choose a carotid CA and arterectomy.
Okay, so you will treat even asymptomatic patient with severe stenosis. Okay.
Yeah.
Okay.
Professor, may I ask you a question? Did you have any cases of restenosis after stenting? And what would be your treatment strategy in those cases for restenosis, if you have any experience in that?
So carotid artery stenosis, carotid artery stenting after restenosis is relatively low. So in our experience, so under 5%. So using the carotid echogram, we check it. And if the restenosis suspected, so we perform the balloon PTA only.
Okay. Thank you for your answer. Okay, are there any other questions? I also see Dr. Jankovic from Germany, from Mainz, our dear colleagues. So maybe Dr. Jankovic has also some question from.
Adi, I could
actually,
ask,
I have no questions. Actually,
Sorry, Ibrahim.
No. Okay, I could later on. Dragan, continue, please.
so Professor, thank you very much for your great presentation. Today I have actually for stenosis no questions, but for endoscopic skull-based tumors I have some.
Okay, thank you, Dr. Jankovic. Professor Kato, you wanted to say something?
No. The Ibrahim, you want to say?
Ibrahim, please.
Just one comment. Thank you for this nice lecture and very impressive results. Unfortunately, in our department, we actually escaped endarterectomy for 20 years, and that's in the field now, which is actually area of vascular surgeon, general surgeon. They are doing endarterectomy, not neurosurgeon. What do you think? Should we take this particular surgical procedure to ourselves, to neurosurgeon again?
So I think so. Vascular surgeon, so handling is very so skillful. That's not so much knowledge about the cerebral vascular perfusion or stroke management. So so I recommended so a neurosurgeon perform the carotid endarterectomy so in your country.
Because we understand much better the brain circulation, stroke incidence, and treatment later on if there's some problems with that.
Yes, that's right.
Thank you, I agree.
Okay. So
In
is it okay?
conclusion of endovascular session, I would like to give also a comment. Thank you for your outstanding lectures from you as a masters in endovascular treatment. As once, I think Professor Henesnimi, there's also a discussion between is the better endovascular or microsurgical treatment, but as Professor Henesnimi mentioned, good microsurgery is better than poor endovascular service, and opposite, good endovascular service is better than poor microsurgery. I believe also in a developmental country as Bosnia and Herzegovina is, we have also to think about cost-benefit analysis of the treatment regarding costs of the coils and stents compared to the simple clipping, microsurgical clipping. Also, that is one issue which we have in our daily work. However, thank you. And is there any other question from the audience, or we can proceed with the endoscopic session?
Dr. Liu, you have some question?
Yeah, thanks, Professor Kato. Thanks, Professor Nakai, for a very nice presentation. I just want to ask Professor, because the guideline says that if stenosis 60% to 99%, both are safe to do. May I know, in your experience, what are the degree of stenosis that we cannot do a cast? If the 99% occlusion, we can still do cast, or in what situation we can't do cast? Thank you, Professor.
Pardon?
So he's asking once after the cast.
Yeah.
So again, the more than 90% stenosis.
Yeah.
Did you repeat the cast or something else?
So previous CAS case, we prefer to the balloon PTA, and if the dissection or plaque protrusion occurs, so stent placement. So stent overlapping is I prefer avoid because so instant thrombosis risk. So so relatively so bradycardia or high blood pressure, hypotension. So was occur. So balloon PT is more safety, I think. It's okay.
Okay, thank you. So Eddie, so please proceed.
Okay, thank you. Thank you for all of your questions and great answers. I would like to introduce Professor Tadashi Watanabe. It's my great pleasure, since I have met Professor when I've been in Nagoya in Red Cross Hospital. Professor is Associate Professor of Department of Neurosurgery, Aichi Medical University, Nagakute. And his lecture is Basic Neuroendoscopy and its Various Applications. Please, Professor Watanabe, give us your great lecture. Thank you.
Thank you for Dr. Adi, and thank you for the invitation, Professor Ibrahim and Professor Kato. So let me share my slides. Thank you for the invitation and it's a great honor for me to talk about my work in front of you in Bosnia and Herzegovina. I heard that the situation of neuroendoscopy is still in progress of development and not fully equipped yet. I'm not sure about the situation in your country. Please forgive me if my lecture does not fit your country needs. I'm going to talk basic neuroendoscopy and its various applications. As a subtitle, neuroendoscopy is not only minimally invasive, it is quick and curative. I am from Aichi Medical University, which is standing just by the university. Let me show you my personal history of neuroendoscopy. This can be said to be the background of the development of neuroendoscopy in me. In 2002, I started my career of neuroendoscopy with ETV, biopsy, and hematoma removal. Then my teacher, Dr. Nagatani, told me about the endonasal approach. Then I developed endoscopic keyhole approach, inspired by Professor Joe. And in the same year, I started cylinder approach as an extension of hematoma removal. Then I met exoscope as a support for endoscopic surgery since 2014. Why is the endoscopic surgery is useful? What are the absolute benefits of endoscopic surgery? It is from small entrance, we can get a wide visual field. It is the most important advantage of the endoscope. This is the picture taken during MBD for facial spasm. Reticus zone is observed by microscope on left side and right side endoscope. Because the endoscope has a wide panoramic view, and the eye itself is inside. We can observe the deep corner with enough illumination. We can look around the corner precisely. Here are the systems for neuroendoscopy. This rigid scope on left side, and on right side, these are the flexible scope. And there is a scope holder. These are made in Japan. It is very useful. Recently, the 4K definition is available. And also 3D endoscope is available, but it is not so popular because it is not yet sufficient performance. This is the exoscope 2D called Vitam 90-degree bistodes. And this one is a Vitam 3D. This is an exoscope. A little larger than the 2D one. And we wear the 3D glasses, and the focus and the zoom are controlled by the hand controller. Here I show you the pure neuroendoscopic surgery with rigid scope and a flexible scope. With rigid scope, we do endonasal approach, ETV, tumor biopsy removal by cylinder approach, and hematoma removal, and tumor removal with a keyhole approach. And with a flexible scope, we do a ETV, septostomy, cyst penetration, and biopsy, and hematoma removal for intraventricular hemorrhage. What kind of diseases is an endoscope useful for? As a classic neuroendoscopy, as a ventricular scope, obstructive hydrocephalus is treated. For hemorrhagic stroke, we can evacuate the hematoma via a borehole with endoscope. For infection or trauma, sometimes this is very useful. For removal of a brain tumor, it is very useful. Of course, for paracellular lesions, endonasal approach is very useful. And for extraaxial tumor like meningiomas, schwannomas, keyhole approach is useful. And intraaxial tumor, intraventricular tumors, cylinder approach is useful. And here I show you the example with flexible scope. This is a case of obstructive hydrocephalus with tactile glioma. This is a picture of third ventricular flow, mammillary bodies, and thin tuba cinerum. And this is the roof of a third ventricle, and you can see the ICVs. And this is posterior commissure and habenar commissure, and the tumor on the posterior wall of aqueduct. The stoma is made by balloon at the tuba cinerum. We confirm the patency of the stoma, and we could get the fluctuation of the flow of the third ventricle. This is postoperative MRI showing a flow void at the stoma. This is another application for ventricular scope. This is a case of NF2 obstructed by the meningeal and intraventricle, and there is an isolated inferior horn. So we put the celastic stent tube between the body of ventricle and the triangle, and partial hydrocephalus is resolved. And these are the endoscopic neurosurgery with rigid scope. I think there are three types of surgery: endonasal, and cylinder surgery, and keyhole surgery. First of all, I mentioned about the endonasal approach. So we use 4 millimeter rigid scope, mostly 0 degree, sometimes angled scope with a pneumatic holder. It is controlled by the assistant. And we sometimes use VEP, extraocular muscle monitoring. And generally speaking, in endoscopic surgery, since the endoscope itself is in the surgical field, the tools hit the body of endoscope. So there is a part that cannot be touched in the surgical field. So position of the scope is very important, and sometimes we bend the tip of the instrument frequently. Actually, we developed special designed instrument for endoscopic surgery, which is malleable but tough and easy to reshape. There's 2 bendable points, which is tough but malleable. And high definition images. High definition process observation allowed us to distinguish the border of the adenoma. So when I cut the dura, I try to keep the pseudocapsule of the tumor and dissect the tumor at the border using a ring dissectors. When the tumor is very soft, suction is of course effective. I prefer 2 suction techniques. One suction is used as a dissector, and the tip is bended as required. Fine control of the side hole of the suction is important. This is a case of a craniopharyngioma beyond the stalk. In this case, we have done a transdorsum cellular approach, and now I am cutting the pituitary gland and dissecting the tumor behind the chiasm, preserving the tiny vessels feeding the chiasm. So now we can use this kind of fine forceps, which is very useful. And I'm carefully dissecting the tumor from the hypothalamus. And finally, the tumor is removed and the cell is reconstructed using a bone flap. This is a postoperative CT and MRI. This kind of huge tumor is also resected by the endoscope, endonasal approach. Professor Goto will show you more complicated cases later. Let's move to the second topic, the cylinder approach. Endoscopic hematoma removal is a basic technique for cylinder approach. Dr. Nishihara reported this approach at the 2000 on JNS, and I followed him, and I started this surgery. With about 1 centimeter in diameter transparent sheath, hematoma is removed by suction with one-hand manipulation. And hemostasis was done by monopolar coagulator connected with suction chip. And almost all the type of the spontaneous hemorrhage can be removed by endoscope. For intraventricular hemorrhage, we use flexible scope to evacuate the hematoma in third ventricle or corner of the lateral ventricles. And this technique is applied for ventricular abscess also. This is postoperative CT. Here are the variations of transparent sheaths. For biopsy, third ventricle lesion, brainstem lesions, small one is used, which is 6 millimeter in diameter. And mostly 10 millimeter diameter sheath is used. But when we require the complicated manipulation with 2 hands, a larger one is used. This is a picture of the OR setup. The most simple procedure is biopsy for tumors, such as malignant lymphoma. After some experience of this procedure, I came up with the idea. The brain tumor can be removed by endoscope. This is my first case for endoscopic tumor removal. This is the metastatic tumor which was growing after the irradiation. The surgery was simple. All I have to do was just remove the necrosis and take the sample of the tumor from the wall of this tumor. It was much easier than hematoma surgery. Mostly one-hand manipulation is done in this case. Then I began the endoscopic tumor removal for small and simple intraventricular lesions. Those were successfully done. This is a case of cavernous angioma at the left triangle. And the patient was an 18-year-old lady who was going to take entrance exam for a prestigious national university in weeks. We performed high parietal approach with 12 millimeter cylinder. and the hematoma, and the tumor was dissected and removed. So now I am doing a manipulation in wet field in irrigating saline. Now it is dry field. So preserving the surrounding veins, mostly the tumor was removed. Okay, this is the final view. And tumor was removed. And this is the postoperative MRI. Now, postoperatively, she was fine, though there was a little decrease of a processing speed, but it was improving. 3 weeks after the surgery, she took the exam, and actually she passed the exam. It was surprising for me also. This is a case of a hemangioblastoma with cystic component. The sheath was inserted into the cyst, and the nodule was observed in front. So we have to do was just remove the nodule. So this is postoperative MRI. So now I'm dissecting the nodule from the wall of the cyst, not to injure the tumor nodule itself. So carefully I'm coagulating the feeding arteries and cutting these arteries and remove the tumor. Okay. Glioblastoma is also a good indication for this approach, especially the tumor is deep-seated one. This is 1 year, 2 years, 3 years post-operative MRI. Sorry. Sorry. I will talk now. This is the case of tribal meningioma. So we put a transparent sheath from the hyperlateral approach and dissected the tumor from brain parenchyma. And after some internal decompression, I coagulate the feeder from anterior choroidal artery and also the lateral posterior choroidal artery. And after coagulating and cut the feeders, I could remove the tumor. Sorry. And tumor is totally resected in this case. This is the postoperative CT. And this is the case of choroidal plexus papilloma of 2 months baby. There was rapidly progressive hydrocephalus, and the emergency surgery was required. As the skull bone was not fixed yet, we didn't want to do a dry field surgery. Otherwise, the child's head will be crushed. So 100% wet field surgery was performed. I mean, a water field surgery. There were the feeders and the drainers confirmed in pre-operative MRI, and those were coagulated and cocked. And the tumor was removed in one piece, finally. So now I'm cutting the feeders and using the clip. We are cutting drainage vein, and tumor was removed in one piece. So this is the last topic, the endoscopic keyhole approach. This approach was inspired by Professor Joe in the Allegheny General Hospital in Pittsburgh. I saw an MVD and an eyebrow approach. Then I started with simple and small lesions. Our technique and the tools have been getting better through some experience. This is a case with thoracomeningioma at confluence of sinuses. It is difficult to remove with a microscope because the lookup visual axis. But with endoscope, it was simple and easy. With a 30-degree endoscope, the tumor attachment was easily observed from small craniotomy. This is post-operative MRI. It is also useful for such cases as a subacute subdural hematoma. In this elderly patient with dementia taking warfarin, subdural hematoma developed during the hospitalization for pneumonia and heart failure. At the onset, she was conscious, but 2 weeks after the onset, she became unconscious, and CT showed subdural hematoma complex in the brain with a midline shift. In this case, endoscopic hematoma removal was performed via a 2 centimeter keyhole at the center of the hematoma with 0 and 30 and 70-degree rigid scope, and hematoma was successfully removed quickly with a minimum invasiveness. In recent cases, we use 3D exoscope. This is the picture of oral setup for exo and endoscopic surgery.
Sorry, no voice. So this is the video of CP angle epidermal cyst. Now the images, I took it from exoscope image. So now surgeon is looking at a monitor in front of him using an exoscope. And after some extent of a tumor dissection and removal, this is still exoscope. It is almost like a microscope. And after internal decompression and some dissection, we change to the endoscope to see a corner, which is invisible by the exoscope. So. Sorry. Okay, this is the view of an endoscope. As you see, that there is a much wider visual field, so we can look around the corner. I'm sorry, I can proceed. Okay, anyway, like this image, we are doing the surgery every day. Okay.
I show you another example. This is the middle fossa meningioma. In this case, when we do a microsurgery for this case, maybe we need a cutting of zygomatic arch. But in this case, I omitted the zygomatic osteotomy. From a small keyhole, we could remove the tumor, especially at the base side. We could remove the tumor from inside. So through this small keyhole, we could remove all the tumor. This is another case, the 83 years old prosocial meningioma. Because there was a bridging vein and a diploic vein just above the tumor, we chose the approach from frontal side. And first we did the exoscopic dissection, and then we changed to the endoscope and observed the parapharazine part, and we could remove all the tumor. Okay. So my conclusion, endoscope is useful for various situations, and it is not only minimally invasive, but also it is quick and curative. Thank you for your attention.
Thank you. Thank you for your attention.
Thank you very much, Professor Watanabe. I think his idea, the treatment with exoscope plus endoscope is, I think, a future, the neurosurgical treatment. The best, I think, minimally invasive for the patient and also the I think, surgeon. Any question? Oh, Dr. Adi?
Thank you, Professor. Thank you, Professor Watanabe, for this great lecture and your great experience. For beginners in neurosurgery who would like to go in the field of neuroendoscopy, what is your opinion? What would be the best pathway to start the development of the neuroendoscopy? And how long the learning curve, since we are all used to microscope, how long, by your opinion, your learning curve and your fellowship should be in one high volume center? And the other question is regarding the transsphenoidal approach and with the tumor with the suprasellar extension. Do you, when I've been with you in a Red Cross hospital, I noticed your heart instrument for suturing the dura. And that's, I think, great instrument for a deep suturing with the endoscope. However, in some cases, we can say, developmental countries or at the beginning, do you use a lumbar drain to prevent the dura leakage? And do you use any other material for suturing the dura or only nasoseptal flap? Thank you for your answers.
Thank you for the good questions. Thank you, Dr. Adi. The first question, what should be, what kind of case is the best to start the endoscopic surgery? In my opinion, as I showed you, there is a variation of endoscopic surgery. So, so maybe please use endoscope in any cases. Please find the utility of endoscope in every cases. Maybe there is some part endoscope is useful. For example, just the ordinary tumor. When you do a normal craniotomy, even if normal craniotomy, there is some corners you cannot see by microscope. Just insert the endoscope and look by the endoscope, and please use to the endoscope. As I said, in endoscopic surgery, endoscopy itself is inside a surgical field, so it is a little bit different from the microsurgery. So we have to used to it. So please use endoscope every time. And as a basic technique, hematoma removal is a basic surgery I recommend. And also the about the endonasal approach, the the simple round pituitary adenoma is best for a young neurosurgeon. And the second question for lumbar, about the lumbar drainage, I don't use a lumbar drainage. Only case when I experienced the leak after the surgery, I use the endoscope. Otherwise, I don't use.
Lumbar drainage.
Yeah, I try to fix. I concentrate on the perfect fixation of cellular floor first, and when I failed of a reconstruction, I use a lumbar drainage. Okay.
If you need to close a bigger defect, please explain to us which technique do you use? Do you use sandwich technique, nasoseptal flap only, or you use some other artificial materials?
Okay. Briefly, for simple adenoma, I don't use septal flap. I use a fat graft and dural suturing. And if there is a good bone graft at the nasal septum, I use a bony reconstruction. And when there is a fragile dura mater or a very big defect, we use a patch graft sometimes and or a septal flap. So for a simple case, I don't use a septal flap. And recently, I sometimes use a Duragen also. Duragen is also useful for the repair of the cell.
Okay, thank you. Are there any other questions regarding this topic? Please, Ibrahim.
Professor Watanabe, thank you for this nice lecture. Great cases, many different approaches, very impressive. So I agree, we should start, yes, from the very beginning, from the basics and easy cases. But however, do you think that for the young neurosurgeon, they should start with EVD or some intracerebral hematoma instead of pituitary surgery first, or with some cystics, or endonasally is first? We have this experience. We started with the transnasal approach, but it's not so easy for the beginners. And a second comment, please, or question. You think that also, let me say, well-experienced and middle-aged neurosurgeon who are spent 20 years with microscope should start with using the endoscope as a assisted tool, even they will never maybe use the endoscope poorly for the surgery.
Okay, thank you for the comment. Yes, as you said, young neurosurgeon cannot touch the brain tumors. Only they can touch the emergency case like ICH, IVH. I recommend intraventricular hemorrhage, and it is, it is getting much easy postoperative course for the resident because there is no hematoma just after the surgery. So they don't need long time IVD period. So I recommend the resident to do emergency surgery first. And as you said, middle class neurosurgeons who is already the master of the microscope, I recommend, as I said before, use the endoscope in every cases. Just prepare the endoscope in any case and just put it inside the surgical field and try it and experience it and used to use it. So I recommend that. So maybe not everybody have to change to pure endoscopic surgery. Microsurgery is, of course, it is a good instrument. So you can do both. That is my opinion. Okay.
But you think everybody should know to use the endoscope, at least for the basics, just to explore the field post-operatively, for example?
Yes,
neurosurgeon or most of them.
If you have the endoscope, if you prepare, I think we should prepare the endoscope at the beginning of the surgery. You know, that is the point. So yeah. When you want the endoscope during the microsurgery, there is no preparation of endoscope. Nobody wants to prepare from at that point. So the point is prepare the endoscope at the beginning of the surgery. So that is my comment and opinion. Okay.
Okay, yes, thank you.
Okay, I think Dr. Dragan has a question.
Thank you very much, Eddie and Professor Watanabe. Great lecture and really great and excellent results, and thank you very much. Here in Mainz, we have a long history from endoscopic surgery, and I have one question about complications. In case of bleeding after tumor resection, or in case of rebleeding after subdural hematoma evacuation, whether you go to endoscopic surgery through small keyhole approach or open surgery. I talk about emergency situation. Also, from your experience, what do you think?
Okay, thank you for the question. Your question is for post-operative hemorrhage
yes.
case. Yes, actually, I used to experience some cases in the beginning of my experience, but for hematoma or intraparenchymal intraventricular tumors, I always confirm the hemostasis by irrigating saline at the end of the surgery. I continue to irrigate for a while, and I don't stop the surgery if the water is not clear. That means there's a bleeding from somewhere. So I try to find them somewhere, the bleeding point. And I always stop the surgery whenever, when those irrigating water become clear. After doing this technique, I don't experience the postoperative hemorrhage. So maybe you can do the technique. And if there is a rebleeding after the surgery, I do an endoscopic surgery. Because I am, I'm an endoscopic neurosurgeon, so I do the endoscopic surgery. Okay.
Thank you very much.
Okay.
Thank you. Please, Dr. Jurlic, proceed with your question.
Thank you, Adi. Okay, thank you, Professor Watanabe, for your great presentation. I have a question regarding the intracerebral hematomas.
Yes.
As you all know, there is still a lot of controversy related to the treating and indication for the surgery for intracerebral hematomas, especially for some deep hematomas. And now there is some new indication regarding the endoscopic approach, even keyhole, even true endoscopic approach for the treating of the deep, for example, putaminal hypertensive hematomas. And there is some new studies ongoing to prove there is a benefit of this kind of operation. In our country, usually in most of cases, we do not treat these deep hematomas. What is your experience in treated of these deep hypertensive, especially some putaminal hematomas, for example, 4 centimeters in size?
Yes, thank you.
Do you have experience there? Is there some clear benefit for this kind of patients?
Yes, yes, of course, I know that there is no clear significant result about the surgery group or conservative group. I know. I think it is very difficult to compare the two groups in a hospital everywhere. So, but in my opinion, after the evacuation of the big hematoma, patient become, consciousness is become conscious, and there is no compression over surrounding brain. So there, the secondary compaction of the brain is removed. So, in my opinion, the rehabilitation and will be much better when we do a surgery. So, nurses and the young neurosurgeon wants to do a surgery for a big hematoma because the management of the patient during the hospitalization is much better, including a rehabilitation. So I think it is worth doing for a hematoma removal. That is my opinion.
Okay. Okay. Thank you very much.
Thank you. We can proceed further. I would like to introduce Professor Takeo Goto, professor and head of the Department of Neurosurgery, Osaka City, University Graduate School of Medicine and School of Medicine, Osaka City, with the next lecture, Endoscopic Approaches to Skull-Based Tumors. Please, Professor Goto, you can.
Thank you. Okay, today I will talk about the endoscopic skull base approach to complicated skull base tumor. At first, I would like to introduce my institute, Department of Neurosurgery, Osaka City University Graduate School of Medicine is one of the largest skull base centers in Japan. So our old mentor, Professor Hakuba, started the transcranial microscopic skull base approaches. And my mentor, Professor Ohata, and I followed his microscopic skull base techniques. I know the microscopic skull base approach is very useful to remove the skull base tumor, but recently, endoscope can offer the panoramic, wide, and clear view to the skull base area, and which contribute to the less invasive tumor removal. So today, I will present our endoscopic skull base surgery, especially focus on the endoscopic endonasal approach and endoscopic keyhole transcranial approaches. At first, I will explain the endoscopic endonasal approach. We already know that we can resect the many skull base tumor by the transcranial skull base approach. But if region located the pure central skull base within this circle, surgical resection seems to be a bit difficult. But recently, endoscopic endonasal approach can offer the same and good view to the central skull base. If we access this area by the endoscopic endonasal approach, the only obstacle to access this area is a bony structure such as clivus, pterygoid process, and petrous bone. So if we adequately drill out the whole bony structure, we can directly access to the central skull base. I will show the several cases. This is the retrochiasmatic craniopharyngioma causing the visual disturbance to her. If we choose endoscopic endonasal approach, we can directly access within the circle of wheels, and then after drill out the bilateral posterior clinoid process, like this, we can completely expose the circle of wheels. I will show our surgical video. This is a cella floor and the tuberculum cella. And this is a pituitary gland. And this is a dorsum cella and a posterior clinoid process. At first, I gently drill out the posterior clinoid and remove the tip of the bone. And this is a pituitary gland. I mobilize the pituitary gland and to the left side and cut the dura mater behind the dorsum cella. This is a tumor capsule, and this is a basilar artery, and this is a PCA. And this is a pituitary gland and stalk. Fortunately, in this case, we can safely follow the border of the tumor. And this is a pituitary stalk. Fortunately, we could preserve the pituitary stalk. I carefully dissect the tumor from the surrounding critical structure, and this is an oblique chiasm. Then, now we achieve the total resection of the tumor with preservation of the pituitary gland and stalk. This is a post-operative MRI. Tumor was totally resected out. We could preserve the posterior pituitary function, but we could not preserve the anterior pituitary function. So we, of course, we need some replacement to her. This is another case of the very large diaphragmacellar meningioma, severely compressed hypothalamus. But in this case, attachment of the tumor was diaphragm. So if we choose the endoscopic endonasal approach, we can directly access the attachment of the tumor. In case of the skull base tumor, directly attach to the attachment of the attachment of the tumor is very important. This is the cell floor. I cut the dura mater and mobilize the pituitary gland to the right side. Now I already completely coagulate and detach the attachment of the tumor. So even the large meningioma, but we can dissect the tumor bloodless surgical field. This is a PCOM and PCA. We carefully dissect the tumor from the perforators, like this. And this is a left optic nerve, and this is an optic chiasm. Now, tumor was almost totally resected out. After resection of the tumor, we have to water-tightly seal the dura mater. I usually put the fat tissue to the subdural layer and put some stitch to put the tension to the dura mater, step by step. And then I seal the large mucosal flap like this. Postoperatively, the old tumor was successfully resected out, and her vision and cognitive function preserved, and also pituitary function preserved. This is another case of the posterior clinoid meningioma. Concept is the same. We can easily access the posterior clinoid by the endoscopic endonasal approach. This is a pituitary gland. I gently mobilize the pituitary gland from the right cavernous sinus. And this is a right posterior clinoid process. I expose the posterior clinoid process and then drill out like this. So now we already access the attachments of the tumor. This is the attachment of the tumor. So I coagulate and cut the attachment. After the completely detach the tumor, we could start the tumor removal with less vascular surgical field. This is a pituitary stalk, and this is the optic chiasm. We dissect the tumor from the perforator and pituitary gland. This is a right carotid artery. Now, tumor was successfully resected out. This is the PCOM and PCA, oculomotor nerve, pituitary stalk, and gland. So posterior clinoidectomy was very effective to this case. Tumor was successfully resected out. without any deterioration of symptom. This is another case of the lower cribal large meningioma, causing the facial spasm on the right side. How to treat this tumor? If we choose the transcondylar approach, we have some risk to damage the lower cranial nerves. And if we choose combined transpetrosal approach, we have some risk to damage the abducens nerve. But attachment of the tumor is completely midline lower clivus. So if we choose the endoscopic endonasal transcribal approach, we can directly access the attachment of the tumor. So I choose the endoscopic approach. I widely drill out the bony structure around the jugular tubercle and the lower clivus, and then cut the dura mater and start the internal decompression. Tumor already devascularized, so we could perform the internal decompression with very bloodless surgical field. This is a basilar artery, and this is a hypoglossal nerve. Now I remove the tumor ventral side of the hypoglossal nerve, and this is the tumor ventral side of the basilar artery, and this is the tumor ventral side of the lower cranial nerves. And then I access more lateral side, and this is the abducens nerve. I carefully remove the tumor from the attachment of the tumor, and finally reach the ventral side of the 7th and 8th nerve. Now the most part of the tumor was successfully resected out. Postoperatively, almost all part of the tumor successfully removed out, and her facial spasm also disappeared. This is another case of the recurrent lower cribal meningioma. Attachment is here, so our strategy is the same. Using the endoscopic transcribal approach, we can access the attachment of the tumor. I widely drill out the lower clivus and then go to the subdural area. Wide bony drilling is very important to access the lower cribal meningioma. When we enter the subdural space, tumor already devascularized. So we can dissect the tumor very carefully, and it's easy to follow the border of the tumor. I meticulously dissect the tumor from the lower cranial nerve. And this is the ICA, and this is the facial nerve. I carefully removed out. And then finally, we resected the whole tumor and preserve the all critical structures like this. Fortunately, tumor was soft, so we could resect out all tumors. Then I will explain the endoscopic keyhole approach, especially focus on the subfrontal keyhole and the subtemporal keyhole approach. At first, I will show the anatomy of the subfrontal keyhole approach. If you put the skin incision around the eyebrow and put the craniotomy with a size of 3 centimeters, and then after insert the endoscope, you can observe the olfactory tract and proximal side of the Sylvian fissure, and then you can confirm the carotid artery and third nerve. And then if you move the endoscope more medial side, you can observe the oblique chiasma and oblique nerve and tuberculum sella, and then can drill out the oblique canal like this. And then After this cadaveric study, we applied this technique to the tuberculum meningioma. At first, I put the small craniotomy on the left side, and then gently insert the cottonoid and endoscope. This is the attachment of the tumor. Brain retraction was minimized, but we can observe the attachment of the tumor. And then I start to open the optic canal. I carefully drill out the left optic canal, and this is the left optic nerve. At the initial stage of the surgery, I could open the optic channel and decompress the left optic nerve. And this is the attachment of the tumor. I carefully coagulate the attachment of the tumor. So we could perform the internal decompression with bloodless surgical field. Now I open the contralateral optic canal and remove the tumor from the canal. And then I resect the tumor totally. This is a bilateral optic nerve, and this is a pituitary stalk. So tumor was successfully resected out. This is another case of the frontal base olfactory groove meningioma. This tumor was safely resected by the endoscopic keyhole approach. This is a surgical view. At first, the size of craniotomy is almost same. I put the frontal keyhole craniotomy and insert the endoscope. This is the attachment of the tumor. Endoscope can offer a very clear and wide panoramic view, so detachment of the tumor was easier than the microscopic surgery. So I detach and devascularize the tumor at the initial stage of the surgery, and then dissect the tumor from the surrounding structure. Now tumor already devascularized. It's one of the benefits of endoscopic endoscopic keyhole approach. Tumor was detached and devascularized. So we could safely remove it out. Post-operatively, all tumor was successfully resected out. Now I will show another case of subtemporal keyhole approach. If you put small skin incision, and then the size of craniotomy is about 3 centimeters. And then after the insertion of the endoscope, you can observe the tentorial edge and also anatomical structure around the trigeminal nerve. Of course, you can open the medial cave and go to the posterior fossa. So through this approach, you can remove by the trigeminal schwannoma. I will show our surgical video. At first, I put small skin incision at the temporal area and perform the small craniotomy, and then insert the cottonoid. This is a dura over the trigeminal nerve. At first, I cut the dura over the trigeminal nerve and then expose the trigeminal nerve itself. I gently cut and expose the trigeminal nerve, and this is a superior petrosal sinus over the medial cave. I cut the SPS over the medial cave. This is a trigeminal nerve, and this is a host nerve. This is a tumor medial side of the trigeminal nerve, and then start the tumor removal. I carefully remove the tumor. In case of the trigeminal schwannoma, subcapsular dissection is enough for tumor removal. So I easily removed out the tumor. and confirmed that tumor was totally resected out. Postoperatively, all tumor was successfully resected out. This is another case of the trigeminal schwannoma. This tumor caused the right trigeminal neuralgia. So I apply the same approach. Surgical procedure was safe. At first, I opened the medial cave and started the tumor removal. This is the carotid artery and the wall of cavernous sinus. I carefully remove the tumor in the medial cave. And then I coagulate the SPS and cut it over the medial cave to go to the posterior fossa. This is a trigeminal nerve, and this is a tumor. I carefully follow the border between tumor and the trigeminal nerve. Under the endoscope, we can clearly observe, identify the border of the tumor. I meticulously coagulate and cut the SPS. And now I reach the posterior border of the tumor. I carefully dissect the tumor from the trigeminal nerve. And I carefully dissect the tumor from the brainstem. This is a thin arachnoid membrane around the posterior fossa. I carefully dissect. This is the tumor occupying the posterior fossa. I carefully dissect the tumor from the surrounding structure, like this. Under the endoscope, we can confirm the clear border like this. So dissection of the tumor from the brainstem is easy, even through the keyhole approach. And finally, all tumor was successfully resected out. This is a pons, SCA, and trigeminal nerve. So I confirm that all tumor was successfully removed out. This is a carotid artery, and this is a wall of cavernous sinus. Postoperatively, also tumor was successfully resected out. This is another case of the recurrent chondrosarcoma associated with osteogenesis imperfecta. For her bony disease, the angle of the tentorial edge was very steep. So to this case, endoscope was very effective. So I choose the same procedure. Using the endoscope, we could get the clear view. So we could dissect the tumor from the brainstem very carefully. This is a trochlear nerve, and this is a trigeminal nerve. I could dissect the tumor from the brainstem. Craniotomy was small, but we could get very clear, wide view around the CP angle. So tumor was successfully resected out. This keyhole endoscopic approach can be applied to the falcotentorial meningioma, like this. Patient shows a consciousness disturbance. So we have to resect the tumor, less invasive procedure. Using the endoscope, it's easy to cut and coagulate the falx and the tentorium. So we place the patient to the lateral position and insert the ventricular drainage to the right side. And I put the craniotomy with a size of 3 centimeters. And then insert the endoscope. This is the falx and this is the tumor. At first, I coagulate and cut to the attachment along the falx. Endoscope can offer the clear view, so it's easy to coagulate the attachment of the tumor at the early stage of the surgery. So we could resect the tumor with less bleeding, and it's easy to dissect the tumor from the surrounding structure. I carefully perform the internal decompression, and this is a deep vein. We could preserve the collateral deep vein like this. So tumor was totally removed with preservation of the collateral flow. Craniotomy was small, but we could achieve the total resection of the tumor like this. So endoscopic keyhole approach also very effective. This is another case of a relatively large falcotentorial meningioma, but our concept is the same. If we choose the endoscopic endonasal approach, we could perform the early detach of the tumor. At first, I insert the ventricular drainage to the contralateral side and put the craniotomy with a size about 3 centimeters, like this. The size is about 3 centimeters. And then insert the endoscope. This is a falx. At first, I widely coagulate and detach the falx. And then start the internal decompression. This is the anterior border of the tumor. I dissect the tumor from the corpus callosum. Endoscope can offer the clear view to the most anterior side. And then this is a falcotentorial junction. We effectively decompress around the falcotentorial junction and continue the internal decompression. In this case, also, we can preserve the deep venous system. So we could achieve the total resection of the tumor with preservation of the deep venous systems, like this. Post-operatively, all tumor was successfully resected out and the deep venous system was also preserved. So endoscopic approach very effective. So as present today, endoscopic endonasal and transcranial surgery can be very effective procedure for removing complicated skull-based tumors. Thank you for attention.
Thank you, Professor Goto. Any question for Professor Goto? It was wonderful, the cases, concept.
Really impressive results, especially those in posterior fossa and combined supracerebral and transtentorial. I like it very much.
So I want to ask Dr. Goto, so you can use all the instruments under the endoscope because it's very tight, the surgical field.
When we perform the endoscopic approach, we need the instrument for endoscopic surgery.
Mm-hmm.
I prefer to use a monoshaft instrument. Bipolar also, I prefer to use a monoshaft bipolar. Of course, the surgical corridor is a relatively small at the entrance, but the deep side we could get the relatively clear and wide view. So, of course, we need the special instrument. So, when we perform the microscopic skull base approach, I use another instrument. So we separate the instrument.
You have any comment on the exoscope?
I don't have the much experience of the exoscope surgery, but I think that in near future, I think the exoscope widespread it. So because it's easy to combine the endoscope and exoscope. So in near future, of course, I want to use the exoscope.
So in your future, do you think exoscope is replaced for the microscope? How do you think about it?
In some field, for example, the tumor surgery, I think the exoscope replace the many field of microscope surgery.
Thank you so much. Thank you.
Professor Goto, also Professor Watanabe, if he's here still. The question, we are trying concerning the training of young neurosurgeons to push the forehand surgery. So a lot of the young neurosurgeon residents to remove the part of the tumor during the surgery, and both are closing the dura and same and so and so. Do you think that some kind of, let me say, overusing on endoscope could reduce the chance for the young neurosurgeons to train by hand? I mean, to get much more experience to doing something during the surgery with experienced teacher.
Thank you for your question. Of course, I think the whole hand procedure very effective to educate the young neurosurgeon. For example, in our institute, many young doctors joined our surgery, and in some part, they hold the endoscope and they insert the one instrument. And it's easy to advise the technique because we observe the same monitor. And we share the experience directly. So in my experience, young surgeon can learn the endoscopic technique in very short period. So I think that to join the surgery is very important. So whole hands also very useful to share the experience. It's my feeling or comment. Thank you, Professor.
Thank you. Professor Watanabe, do you want to comment this? I mean, could young neurosurgeons benefit by endoscope, using endoscope every day?
Basically, we are also doing a team surgery, not only one surgeon. There's a main surgeon, manipulator, main surgeon, and assistant, and the second, another assistant who is holding the endoscope or exoscope. Actually, the scopes, we call it scopist. Scopist is need to understand the surgery and have to move the endoscope, as the surgeon want to. So as Professor Goto said, the scopist, there's a chance to learn surgery when the resident is doing the scopist. So team surgery is one of the important keywords for the endoscopic surgery.
Thank you. Thank you.
I have just a comment to Professor Goto. Outstanding lecture and results, and thank you for sharing your experience to us. And as we know, as we have noted, that early devascularization is one of the advantage of the endoscope, especially for the transnasal surgery. And the other great advantage is that we are not using retractor at all. So we all know that from some studies, retracting the brain can cause serious damage and with serious, especially cognitive consequences later on during follow-up. And that was just my comment. I don't have questions, but I wanted to thank you a lot for sharing this great experience with great cases and tough cases. Thank you so much. If we have other questions from the audience, please, Dr. Almir.
Okay, thank you, Professor Goto, for your impressive lecture. I have one question regarding the treating of the tumors of the anterior fossa tuberculum cellae, planum sphenoidale. You showed us cases treated both. Some of cases you treat with an endonasal approach, and some of cases, for example, in some planum sphenoidale meningioma, you treat with a keyhole subfrontal endoscopic guided approach. So which approach would you choose in some cases, for example, 2 to 3 centimeters planum sphenoidale meningiomas, and in a cases of the transsphenoidal approach, how you will close the defect, dural and the bony defect? Is there some special technique? Thank you.
Thank you. When we treat the tuberculum cell meningioma, we basically use a three approach. One is endoscopic endonasal, and one is keyhole endoscopic endonasal, and three is transcranial interhemispheric approach. We choose the three approach based on the attachment of the tumor. Even the size is looks large, but the attachment of the tumor is not wide. In such case, endoscopic endonasal approach very effective procedure to the optic chiasma or optic apparatus. But in some cases, tumor was very large and severely attached the distal part of the ACA. In such case, we need transcranial interhemispheric approach. And the size is not large, but attachment of the tumor is over the optic canal. In such situation, I think keyhole endoscopic approach very effective. So considering the attachment of the tumor and the size of the tumor, we choose the three approach. And
okay, for the closing defect.
Sorry?
And for the closing of the bony defect and dural defect after the removing the...
When we perform the tuberculum cell meningioma, I not use bony reconstruction. I suture the dura mater. Usually, I insert some fat tissue to the subdural layer and additionally suture the dura mater, and then cover the large mucosal flap.
Okay, thank you very much.
Can I ask a question?
Please, Dr. Noda.
Yeah, very impressive presentation. Thank you, Professor Goto. My question is, if you do the endoscopic surgery for trigeminal neurinoma, if there is some venous in just in front of the operative field, how do you remove widen the operative field?
Thank you. In case of the trigeminal schwannoma, I usually endoscopic subdural temporal approach. Our surgical corridor is actually not large, very small. So usually we not encounter the cortical vein because surgical field very small. But at the deep side, we can get the panoramic view. So we rejected out the trigeminal schwannoma.
Thank you very much.
Okay, any other questions, please? Okay, then we can move to our last lecture by Professor Kosumo Noda, Cerebrovascular Bypass Surgery Step-by-Step Guide. Please, Professor Noda.
So first of all, I would like to thank Professor Yoko Kato and Professor Ibrahim and Professor Lucas and the ACNS staff for giving me this opportunity. So he is the former coach of Japanese national soccer team. He is very well known as philosopher of soccer, and many books about him are available in Japan. We still have a great respect for him, and I'm honored to be here with you today. Thank you. So this is his word, one of the most famous things he said. He was emphasizing the importance of preparation and the sense of professional responsibility. I think this is also true for us neurosurgeons. I believe that it is important to pursue basic techniques without neglecting them. So today I want to talk about these four things. So the principle in the anastomosis is abating suture and fish mouth trimming and maximum zooming and bloodless field. Wide and shallower and large field, large vessel is easy to do the anastomosis. And in opposite, the narrow, deep operative field and small vessel is always difficult. So at first start with trans-Cerebral approach, very basic surgical technique. Very usual case, the right side MCA aneurysm. I want to show you how we do the operation as usual. So right side, the front temporal approach, and we always respect to the layers and reflecting the temporal muscle. Don't cut the temporal muscle and do the craniotomy. And this is the surface, and from the preoperative CTA, we can understand where is the aneurysm. And in this case, the MCA is very elongated. So in the Cerebral fissure, Cerebral system, the aneurysm is a little bit complicated. So trans-Cerebral approach, we always emphasize on the lift up. To lift up the veins, we can visualize the adhered point like this. And this is the one of the techniques, the lift up the veins. Then we can go deeper. And in this case, the M2 trunk of the inferior trunk of the M2 is elongated, and they are attaching to the frontal lobe. So we have to understand this vascular structure and find the correct way to do the approach. So detaching the M2 inferior trunk from the frontal lobe. So this is the coronal section. So the post-inferior trunk is elongated. So we have to go this way, not this way. So we can smoothly dissect the Cerebral fissure. And there is an aneurysm here. And detaching the surrounding structures, and we can put the neck clipping. So this video is actually from the textbook for the resident. We always educate the resident like this way. Okay, complete neck clipping was performed. So this is a post-operative illustration. So what I want to say is it is important to determine whether each branch of the MCA belongs to the left or right. We have to distinguish the way. And by lifting the tissue, the visibility of the tight adhered area is very visualized. Okay, and next case is also the boring case, the right MCA and the paraclinoid aneurysm, and very usual case. That this case is the paraclinoid aneurysm. We do the anticlinodectomy and open dura. And the Cerebral vein is, in this case, the Cerebral vein is complicated. So what we can learn from this case is the denuding technique. So we always denude the Sylvian veins from the arachnoid trabecula, arachnoid membrane. Then we can stretch out the Sylvian vein so we can get the wide operative field. To do the denuding the Sylvian veins, we have to understand the structure of the arachnoid membrane. So then we can go to the aneurysm. Aneurysm is just behind the temporal lobe, but it is not good enough. So much more widen the operative field. So we have to stretch the veins and denuding the arachnoid. To do this, here you can see the tubular structure around the Sylvian vein. We can, if you understand the structures, it is easy to dissect the Sylvian veins. So here you can see this is the schema. There is an arachnoid tube around the Sylvian vein. And now we can widen the operative field like this. So we can go to the MCA aneurysm. So our very important philosophy is never cut the veins. So if the very tiny vein is there, we never cut the vein. Then we can go to the paracrinoid aneurysm, remove out the distal dural ring and see the aneurysm, and put the temporary clip and the neck clipping to the paracrinoid aneurysm. Then we can go to the MCA side. Here is the aneurysm and here is the M1. We can secure the MCA and neck clipping. So this kind of approach is our basic. So to do the denuding technique, we have to understand these Sylvian membranes. So outer arachnoid membrane, just under the superficial Sylvian vein, there is a lateral Sylvian membrane and intermediate Sylvian membrane and medial Sylvian membrane. And the denuding technique, we can pull out the outer Sylvian membrane. We can find the tubular structure surrounding the superficial Sylvian vein. When we find it, we can insert the scissors and easily dissect the denuding the Sylvian vein. To do so, we can eliminate the need for direct dissection in between the Sylvian vein and the Pyer vessel on the brain surface. The next case is the right ICPC ruptured aneurysm retrograde suction decompression case. This patient coming to our hospital by minor leak and slight headache. CTA shows the about 8 millimeter ICPC aneurysm. So preoperative illustration, we discussed and determined we need to do the suction decompression for the patient. The FREA image shows the slight subarachnoid hemorrhage around right ICA. So starting from the neck dissection, the platysma, external jugular, sternocleidomastoid mastoid here. And this is the suprathyroid artery. And open it. And inside the infant feeding tube. This is the preparation. And as I said, we always respect to the layers. So anterior, periauricular muscle anterior, and the temporal side, we always do the just above fascia and just below garter in frontal side. To do this, we can change the operative strategy to the bypass. If we do the one layer operation, it is very difficult to do change the strategy to the bypass. Here, starting from the distal transcerebral approach, and there is a very slight subarachnoid hemorrhage. Inside the intermediate cerebral membrane, we can see the subarachnoid hemorrhage, and the proximal cerebral membrane was opened, then the CSF coming. And widen the operative field. And dissecting the anterior temporal artery from the surface of the inner surface of the temporal lobe. We can widen the operative field posteriorly. As expected, the aneurysm is just under the tentrium. So less stress on temporal lobe due to the wide opening of the cerebral fissure. Here is the anterior choroidal artery. Now temporary clip to the CCA. Then dissect the anterior choroidal artery and the distal neck. This is a ruptured point. Then put the temporary clip to the distal and start the retrograde suction decompression. So shrink the aneurysm. We can see the posterior communicating artery. Here is the schema, the inside the tube to the superior thyroid artery. Then we can get the very good operative view, the backside of the aneurysm. And neck clipping. Then we can cut the aneurysm. And here is anterior thermoperforating arteries. So these are our usual operation for the ruptured and unruptured aneurysms. This is daily work. So this illustration means the purple arrow is the visual axis, the bilateral visual axis, and the green arrow is the optical axis. What I'm trying to say here is that the orbital skeletonization secures the optical axis of the microscope and makes it possible to create brighter surgical field. This is the retrograde suction decompression. A cannulation tube insert in the supracellular artery and the retrograde decompression was performed. In this way, it was possible to see the backside of the aneurysm. Okay, so next is the STA harvesting technique. This is very old video, but very fundamental technique. We always dissect the just on the STA parietal branch and expose the STA. We have to understand the layers where STA runs through. So in the distal side, STA is just above the galea, and the proximal side, they're penetrating the periauricular frontalis. Then to understand this kind of the anatomy, we can dissect harvest the STA safely. Okay, so this is the periauricular anterior and the superior, and the STA runs through just under the anterior auricular muscle and penetrate it, and just above the galea they run through. So here is the example. For moyamoya disease, STA, MCA, and the STA, MCA double bypass and the STA, ACA bypass was performed in the left side. The right side was already done. Starting from the STA harvesting, we always pay attention to the layers where the STA runs through, and harvesting the STA parietal branch. After that, we can harvest the frontal branch. In this case, we did the galea flap to the frontal lobe. Then this is a temporal muscle, left side temporal muscle. So myosynangiosis was performed. So get ready for the myosynangiosis. And widely open the temporal side. Pay attention to the middle meningeal artery. Because we want to do not only the direct bypass, we want to do the indirect bypass to the lesions. So MCA distal side. So this is a standard bypass. So around 1 millimeter or more, we do the abutting the arterial wall and the intima to intima stitching. The important thing is bloodless field and maximum zooming and abating the vessel wall. So in this case, we did the STA-MCA double bypass and the STA-ACA single bypass to the patient. This is a STA-MCA and the STA-ACA. This is the final bypass to the STA, the MCA of the temporal lobe. Gallery flap to the left frontal lobe. And the myosynangiosis. And okay, so this is the postoperative CTA, shows very good flow to the frontal and the temporal lobe. Okay, and the next topic is surgical thrombectomy as salvage surgery. So since the Nashville Hope in 2014, endovascular therapy, mechanical thrombectomy has become a common treatment for cerebral embolism. And we have been reporting the usefulness of surgical thrombectomy for a long time, but after 2014, we changed our policy and performed the IVTPA as the first line and the mechanical thrombectomy as the second line, and open surgery as the third line to improve the outcome. So here is our strategy from 2017 to 2021. The 118 consecutive cases are here, and 118 and 9 cases are treated by surgical thrombectomy as third line. Our criteria is here. So the summary is like this. This is the summary of the cases. A little bit complicated, but the outcome is not good, but we can save the patient. But the one case, the one perforation case, the ICA perforation, we lost the case. Okay, here is the illustrative case, the mechanical thrombectomy ineffective case. The 66 years old female, NIHSS, the 13 onset to ER is 12, and the door to puncture is 1 hour and 1 hour and a half, and puncture to OR is 2 hours and a half. At first, the patient coming to a hospital, left M1 occlusion. We try to do the IVTPA and the mechanical thrombectomy, but the thrombus is so hard, so it is difficult to remove the thrombus. So we change the way and go to the OR, and just after 20 minutes, we can secure the occlusion point. But the artery is not the only thrombus, but there is a very hard sclerotic change. So we changed the way harvesting the STA, and the STA-MCA bypass was performed. And posterior trunk and the anterior trunk, the double barrel to the MCA was performed. The post-operative diffusion image, we can save the cortical of the MCA. So, but the right hemiplegia cannot recover. The next case is left M1 occlusion case, the perforation case. The 69-year-old male. At first, we tried to do the IVTPA and the mechanical thrombectomy for the left M1 lesion. And the vascular surgeon tried to remove the clot in the left MCA, and part of it are removed. Then try to remove more, then the extravasation was seen, the penetration of the MCA. Then we rush into the OR, and here is a bleeding point. You can see, and put the temporary clip and remove the clot. You can see the perforation here. So we can suture it immediately and recanalize the anterior trunk of the left side MCA. And the posterior trunk is here, still occluded. So we can put the arteriostomy and remove the clot directly. So puncture to recanalization is 2 hours, over 2 hours. Okay, so anyway, the prognosis of a vessel perforation is poor. So in the literature, they insist that if hemostasis is not achieved, occlude the mother vessel. But our strategy is move to craniotomy immediately. And first pass effect is well known. So our strategy is, the limitation is 1 hour. So we begin the preparation for craniotomy in approximately 1 hour. It is important to maintain a system in the hospital that allows for the transition to craniotomy at any time. Anyway, finally, I will talk about the techniques of vascular reconstruction in posterior circulation, about the OA pica bypass. This is right side. We do the OA pica bypass. We make the skin incision in layer by layer fashion and dissect the muscles and do the transcondylar approach for the lesions. To do this, we have to understand the precise anatomy of the muscles and understand the layers of the occipital artery which run through. So this is the animation about that. Okay, so steps of OA pica bypass. This is left side. The occipital artery is running through just lateral to the longissimus capitis muscle in the suboccipital region, then occipital artery runs through just beneath the splenius capitis, and in the middle of the splenius capitis, they the occipital artery penetrate the sternocleidomastoid fascia. Then the occipital artery is in the subcutaneous segment. Here is an intermuscular segment. We have to understand the anatomy. So at first, we elevate the skin flap and expose the subcutaneous segment of occipital artery, and find the penetrating point of the sternocleidomastoid. Then we can reflect the sternocleidomastoid to the lateral and the splenius capitis to the inferiorly. Then we can harvest the occipital artery, still there opening, and remove to the outside of the operative field, and digastric muscle and longissimus muscles, semispinalis and superior oblique, rectus capitis posterior major and minor. Then we can find the condylar fossa here. Then we can do the transcondylar fossa approach to the suboccipital lesion, and we can see the pica, the lateral medullary segment. We can do the OA pica bypass like this. So this is the case, the left VA dissection, the 47 years old male. He came to our hospital because of the left VA dissection is growing, and the transfer from the other hospital. The endovascular surgeon asked us to, because there is a perforator from the aneurysm. The pica is here. This is left vertebral artery, and this is aneurysm. The perforator is arising from the proximal of the aneurysm. That is the problem. So we decided to occlude the vertebral artery with occipital perforator bypass. So starting from the skin incision, respect to the layer, hemostasis, meticulously, we can find the occipital artery here, the subcutaneous segment. Sternocleidomastoid is here, and here is the occipital artery. Now dissecting the occipital artery subcutaneous segment. There is two branches, so we can harvest both of them because the perforator is so small. So we need the small occipital artery branch. Around the penetrating point of the sternocleidomastoid, there is a very hard tissue. So we have to be careful not to injure the occipital artery. And elevating the skin flap, you can see the trapezius muscle. This is the left side trapezius muscle, and this is the sternocleidomastoid. Now, inside the the sternocleidomastoid mastoid and elevating it, you can see the splenius capitis just under the sternocleidomastoid. Now we can palpate the mastoid tip. Then detaching the splenius capitis from the supranuchal line. And here, just under the splenius capitis, there is the occipital artery. This case is the occipital artery is running lateral to the longissimus capitis. It's not so common. This is occipital artery, harvesting it. And this is the longissimus capitis just under the occipital artery. Detaching the longissimus capitis. And now inside the occipital muscle and elevate it, we can see the skull, the suture of the skull. And here is semispinalis capitis. Dissect it and elevate to the medial side. This is a semispinalis. Elevating. Then you can see this is the superior oblique muscle. Elevate the superior oblique. Just under the superior oblique, there is a vertebral artery. We have to be careful to the vertebral artery. In this case, we detach the superior oblique, and this is the rectus capitis posterior major. And remove the fatty tissue. You can see the vertebral artery here. In this kind of operation, we always secure the vertebral artery to do the proximal control, just in case. This is a condylar emissary vein, foramen magnum. So the situation is like this. Already harvest the occipital artery and outside of the surgical field. And here is a posterior condylar emissary veins here, and the condylar fossa, vertebral artery. Now we can cut the condylar emissary vein. Then we can do the craniotomy. The foramen magnum, opening, and drill to the lateral side, and the sigmoid sinus skeletonization is performing. Condylar fossa. And this is the condylar emissary vein. And here is a hypoglossal canal. Here should be the hypoglossal canal. And expose it. confirming the hypoglossal nerve. So the situation is like this: the vertebral artery and hypoglossal canal here, and the jugular tubercle is here. Then open the dura mater, select the brain, and here is the accessory nerve. Foramen magnum is here. Elevating the cerebrum, you can see the lower cranial nerves here, and you can see the artery arising from the dissecting point. So this is the perforator to the medulla oblongata. Here is a pica and the 6th nerve and the 7th, 8th nerve. And ICG shows the perforator is coming from the aneurysm itself. So preparation for the OA perforator bypass, cut the occipital artery, in this situation, the problem is the size discrepancy in between the occipital artery and the perforators, because perforator is less than 1 millimeter, about the 0.5 to 0.7. So we need the branch of the occipital artery and put the temporary clip. This kind of deep and narrow operative field and small vessel is the bypass is very difficult, this kind of situation. So we always start the heel and two. Now suturing the heel side of the occipital artery. And the two side. So we always do like this, the everting fashion. If the artery is very small, but the technique is always same, the everting and the maximum zooming, and the visuality is very important. This case, this stitch is not good, the back stitches. So take out the suture and re-suture the heel side. Here is the everting suturing. Okay. Finally, okay. The anastomosis is performed, and this is the final stitch. The two side. Bleeding from the occipital artery. and open the occipital artery. The ICG shows the very poor flow because the proximal is opening. Then put the temporary clip to the proximal side of the perforator. The blood supply from the occipital artery is coming to the medulla oblongata here. This artery is very wide blood supply. Then put the permanent clip to the proximal of the aneurysm. Then put the clip to the perforator. The blood supply is very good. So we can close the wound. Okay, this is a postoperative CTA, and the diffusion image shows nothing happened. The patient have no deficit. And this is how we do the bypass. The to and here is very important, and the problem is always easily happen in the heel side. So again, the principle in anastomosis is everting and fish mouth, maximum zooming, and a bloodless field. And anatomy is very important. Thank you very much.
Thank you, Dr. Noda. Wonderful talk. So any question to him, Dr. Ibrahim?
Thank you, Professor Kato, and thank you, Professor Noda. Very nice lecture, but it's not easy. Actually, surgery is very complex. Surgery have needs for years of training, like the fellowship. However, some young neurosurgeons start with training or trying to do bypass surgery. What you actually recommend to start with which kind of case, which is a simple, more simple, very easy case, for example?
We always do the practice in the OR in the midnight with the plastic tube. Then the first case should be the insurance bypass. No damage to the patient. If he failed, if the young doctor failed, the patient have no damage. So the insurance bypass, we always
start with that.
Yeah, start with that. Yes.
Okay. Thank you.
Eddie?
Dr. Noda, please, first, before I forget, Mrs. Claudia Gomez, who is attendee, asked about the handbook which you have showed us. So please, you can go to chat and just write the name of your handbook so she can find it for studying. That's the question in the chat. Thank you for this wonderful lecture. Actually, I have first one basic question. As I noted also in Fujita when I've been there with Professor Kato, and as I noted from your presentation, that you always do a temporal side sylvian dissection. So by our experience, we almost always go from the frontal side of the sylvian veins. And please, can you explain us which is the difference between those two types of dissection and what is the advantage to go from the temporal side? So you can answer now, and later on, I will ask you the other question too.
Yeah, always we are asked that kind of question. If you start from the distal side of the sylvian fissure, I think we have to start from the temporal side. But in the proximal side of sylvian fissure, the vein always go to the temporal side. So that is the the same transcerebral approach, but the starting point is different, I think.
Thank you. And how long of bypass surgery practice do you need for one time frame of 20 minutes of bypass? So how long should a young neurosurgeon practice, I mean, in a lab or any kind of practice to establish that kind of speed? And is there any kind of continuous stitching, not just interrupter suture? Is there any kind of continuous stitching to be faster, to not to be too risky for the patient?
Yeah, we prefer to do the intermittent suture. So if the continuous suture failed, the whole of the stitch, we should take it out. But the intermittent suture, we can take out the one suture, only one suture. And the first question, how long the training has to do the training? Depends on the person. Depends on the person. But anyway, we don't think about the suturing technique is important, but the important thing is how to make the operative field to do the surgery easier. So bloodless and widen the field and bright field. We think that it must be the important much more.
And do you use any protective drugs when you do a proximal clipping before starting a bypass, like Sendai cocktail or any kind of drugs? What is your strategy to protect the brain from this ischemia during the bypass procedure?
Yeah, usually we don't use that, but in case of the very giant and difficult aneurysm, we sometimes use that kind of drugs, but it's very rare.
So if you have, for example, for a beginner, like 40 minutes bypass, do you think it's gonna influence the outcome? For example, STA, MCA bypass for the beginners. If you start, you cannot make it in 20 minutes. So if you enlarge your time frame, how it's gonna influence the outcome? So what would be the strategy to have the best possible clinical outcome in these cases?
Yeah, actually, I'm not sure. It depends on the patient. If there is a good collateral flow, we can waste a lot of time, but no collateral flow, the 20 minutes is too long, I think. Depends on the patient. But anyway, if you take more than 20 minutes, there must be some problem in the procedure. So we have to check it and yeah.
And about heparinization, how much of heparin do you use in a donor vessel? Do you use a special amount of heparin, or you can answer, what is your opinion?
Usually we don't use the heparin, but in Moyamoya case, we have some trouble, so we use the heparin. But if you do the proximal occlusion for the aneurysm treatment, we always take the aspirin before operation, administer the aspirin 1 week before operation.
1 week before. Mm-hmm. Thank you. Are there any other questions from the audience? Okay, Professor Kato, then we can proceed to conclusion.
Thank you very much. Thank you for Noda, the excellent lecture. So it's come to the conclusion, I think. Maybe Professor Ibrahim, you want to say something? It's
Yes,
Ibrahim, you have.
thank you. That was a very nice meeting, even much better than I expected, to be honest. And I would like to thank you, all of you, especially lecturer who prepared wonderful lectures, not only for the young neurosurgeons, but also for us seniors. Thank you, Dr. Liu and Dr. Adi, who spent your time and energy to collect all of us here. And of course, thank you, our leader and Professor Yoko Kato, who spent whole life to teach the people around the world. During these lectures today, during these small breaks, we actually, Professor Kato had an initiative, and me, we exchanged few emails and make a deal to continue this cooperation. And Professor Kato actually offered to arrange another one meeting in May. So Professor Kato, thank you. I would like to say this, just these few words. Maybe you can explain much more about the functional meeting and gliomas. So we'll continue. I hope see you all again in May.
Okay, thank you so much. So before closing, the Dr. Lucas.
Professor Kato.
Yes,
Professor
thank you very much for your patience.
No, it was my pleasure. It is always my pleasure, Professor Kato, dear Ibrahim, and all colleagues, dear distinguished experts in the field from Japan. Thank you very much for your outstanding work and educational activity of the top class level. And this is very important for us. Thank you for your patience on the first place to answer on all questions. I believe that next activity will be here in continuity in terms of what Ibrahim and Professor Kato just mentioned, to be useful for all of us. And we could learn a lot of things from this outstanding webinar. And I wish you all the best, and I would like to see you all in person very much as soon as possible. So thank you once again.
Thank you so much. So maybe the one word from Professor Goto.
Thank you for organizing this good meeting. I felt very honored to join this meeting. And then I hope that this workshop will continue for a long time. And I hope in near future, I would like to visit Bosnia Herzegovina after this COVID pandemic. Thank you.
Thank you so
You
much.
are all invited. You are all invited, Professor Goto, of course.
Thank you.
Well, thank you so much, Professor Goto and Professor Nakai. Please unmute.
Okay. Thank you very much. So I'm very honored to join this webinar. So I also want to visit the Bosnia Herzegovina. So thank you very much.
Okay, so Professor Noda.
Thank you for everything. I learned a lot of things from the professors. Thank you very much. I want to be there too.
So Noda mentioned because his textbook is written in Japanese.
Yeah.
So it's very sorry, but maybe he can provide some video if you wish. I think you can get some video from Professor Noda, and then you can see every day, please. And
Yes,
Dr. Liu?
please. There is a Claudia. You can maybe contact Professor Noda about exchanging videos or other educational activities. Okay, Dr. Liu?
Yeah, thanks, Professor Kato. And I hope to see you all again in May. We will announce the program soon by March, probably. Thank you.
So thank you very much for, because I at the beginning I planned just 2 hours the conference, but it's almost I think almost 4 hours. I think it finally they became a very long the webinars. But I think 5 speakers, those are the very excellent talk, and hope it will some the use for especially the young neurosurgeon in the Southeast, or at least, of course, the Bosnia Herzegovina. And I think everybody said the same things: the anatomy and indication and the strategy and the skill. And finally, everybody needs some instruments. So those things is very, very important to learn the excellent, the final result, I think. So we wish continue our webinars in the future. I think maybe not only the one way, maybe the exchange our opinion and the results in the future. I really appreciate Professor Ibrahim and also the Lucas and also Almil and of course the Adi. We all thank you very much for your great effort to make some such a wonderful webinar. So to see you in spring.
Thank you. Please keep in touch, all of you, and we will exchange our opinion in the future. Adi,
thank you very much. All the best. Thank you.
I just want to
all the best
to all our professor, arigato gozaimashita, and hope to see you soon. As I mentioned to Dr. Dragan, who is from Mainz, he told me just in message that this was one of the best webinars he ever attended. And I mentioned to him for it's like a Lexus car, you know, you have BMW, you have Mercedes, but the Lexus is the best car. Like when you have Takumi Masters there. So you are Takumi Masters in neurosurgery, and hope to see you again. Special thanks go to Professor Kato, who organized and who is our host. And also I would like to thank Dr. Liu, who shared all of his emails. And looking forward to see you soon in Bosnia and Sarajevo.
Thank you very much. Okay. So good afternoon and good night.